For those unfamiliar with the iceberg format, at the surface are the most familiar disorders, the ones everyone has heard of, but the deeper we go, the more rare, more strange, and disturbing the disorders become. What begins with everyday labels soon turns into conditions few have ever encountered, buried in the depths of the human mind. Depression. Depression is described as a state of long-lasting emptiness, loss of interest, and heavy fatigue. Unlike temporary sadness, it lingers for weeks or months, affecting sleep, appetite, and ability to focus. People often report feeling slowed down, disconnected from others, or unable to enjoy things they once valued. Researchers link it to chemical changes in the brain, especially systems that regulate mood and motivation. Genetics also play a role, as it can appear more often in certain families. Stressful life events and long-term pressure are known to trigger or intensify the condition. There are many forms, from mild episodes that quietly drain energy to severe ones that disrupt nearly every aspect of daily life. Even though depression is common around the world, it is often misunderstood, with people reducing it to simple sadness when in reality it is a much more complex state. ADHD. Attention Deficit Hyperactivity Disorder is defined as a persistent difficulty in focusing, controlling impulses, and regulating activity levels. It is usually noticed in childhood when teachers or parents observe that a child cannot stay still, loses track of instructions, or interrupts others. In adults, it can appear as chronic disorganization, forgetfulness, or problems with planning daily life. Researchers explain ADHD through several factors. Some point to differences in brain structure and how certain chemical signals work. Others underline genetics, showing that the condition often runs in families. There is also evidence that early environment, such as stress or lack of routine, may increase its expression. The condition is often divided into three main types: inattentive, hyperactive impulsive, and combined. This means that some people mainly struggle with concentration, others with impulsive actions, and many show a mix of both. ADHD is one of the most widely recognized behavioral conditions in the world. At the same time, its borders are still debated. Some claim that it is overdiagnosed, while others argue that many people remain undiagnosed. This uncertainty makes ADHD a condition that is both well known and yet not fully understood. Anxiety. Anxiety is described as a constant state of tension and expectation of danger, even when there is no real threat. Unlike short stress before an exam or meeting, this feeling stays for long periods and interferes with daily life. People may feel their heart racing, muscles tense, or thoughts looping endlessly about what could go wrong. Researchers explain anxiety as a mix of brain chemistry, genetics, and environment. Some individuals inherit a stronger reaction to stress, while others develop it after difficult experiences. It can appear as generalized worry, sudden panic attacks, or specific fears connected to certain situations. Mild anxiety can push someone to prepare better, but when it becomes chronic, it drains energy and focus. The condition shows how the body's natural alarm system, designed for protection, can sometimes remain switched on without pause, shaping how a person thinks, feels, and acts. Bipolar. Bipolar disorder is defined by unusual shifts in mood and energy. A person may go through periods of extreme activity and confidence, followed by phases of deep fatigue and emptiness. In the active state, often called mania, they may sleep very little, speak quickly, and make bold decisions without caution. In the opposite state, known as depression, motivation fades, and even simple tasks feel heavy. Researchers suggest that bipolar disorder has strong genetic roots, appearing more often in families with a history of mood conditions. Brain imaging studies show differences in regions that control emotion and decision-making. Stressful events or irregular sleep can trigger episodes, but the underlying pattern is long-term. There are several forms, from severe cycles of mania and depression to milder patterns with shorter shifts. Despite the intensity, many describe periods of creativity and productivity during elevated moods. This dual nature makes bipolar disorder one of the most striking examples of how the human mind can move between extremes. Autism. Autism is described as a developmental difference that shapes how a person communicates, learns, and experiences the world. Signs usually appear in early childhood. Some children may avoid eye contact, use unusual ways of speaking, or prefer routines and repetition. Others show very focused interests or advanced skills in certain areas while struggling with social interaction. Researchers link autism to differences in brain development and genetics. It is not caused by one single factor, but by a combination of influences before and after birth. Studies show that the brain of a person with autism processes information and senses in unique ways, which can make everyday situations feel overwhelming or, in some cases, unusually fascinating. Autism is not a single condition, but a spectrum, meaning it ranges from mild forms, where a person lives independently, to more complex forms with strong support needs. This wide variety shows that autism is less about a clear border and more about diverse ways of existing and thinking. Social anxiety. Social anxiety is described as an intense fear of being judged or embarrassed in everyday interactions. A person may avoid speaking in groups, meeting new people, or even simple tasks like making a phone call. The body often reacts with blushing, trembling, or a racing heartbeat, turning ordinary situations into sources of distress. Researchers explain it as a combination of inherited sensitivity, past experiences, and brain activity in regions linked to fear and self-awareness. Many people with social anxiety report that even minor mistakes feel magnified, as if everyone is watching closely. The condition can range from mild discomfort in large crowds to severe avoidance of nearly all social contact. Unlike ordinary shyness, social anxiety persists over time and interferes with daily life. It reveals how deeply humans are wired to seek acceptance and how powerful the fear of negative attention can become. Dyslexia. Dyslexia is a learning disorder that affects reading and writing skills, despite normal intelligence and access to education. The most common difficulty is recognizing written words and matching letters to sounds. This makes reading slow, effortful, and prone to mistakes, even when the text is familiar. Beyond reading, dyslexia can influence memory, spelling, and the ability to quickly process information. Some individuals struggle to keep track of sequences like phone numbers or instructions. Handwriting may appear uneven, and written expression can lag behind spoken ability. Brain imaging shows that people with dyslexia use different neural pathways when reading. Activity in the left hemisphere, where language is usually processed, appears reduced, while other areas work harder to compensate. Genetics also play a role, as dyslexia often runs in families. The condition is not linked to lack of intelligence. Many individuals develop strong problem-solving skills, creativity, or visual thinking as they adapt to reading difficulties. Dyslexia highlights how the brain can process language in ways that differ from the standard model of literacy. Schizophrenia. Schizophrenia is a complex mental disorder that affects how a person thinks, perceives reality, and interacts with the world. It is characterized by a combination of symptoms, often divided into positive, negative, and cognitive. Positive symptoms include hallucinations, delusions, and disorganized speech or behavior. Negative symptoms involve reduced emotional expression, lack of motivation, and social withdrawal. Cognitive symptoms affect memory, attention, and problem solving. Hallucinations are most often auditory, with voices that comment, argue, or command. Delusions can take many forms: persecution, grandiosity, or bizarre beliefs disconnected from reality. Disorganized speech reflects fragmented thinking, with sudden topic shifts or invented words. These features together create a distorted sense of reality that is difficult for others to understand. The onset usually occurs in late adolescence or early adulthood. It often develops gradually, beginning with subtle changes in thinking, mood, or functioning before a full psychotic episode. The course of schizophrenia varies. Some individuals experience periodic relapses, while others live with persistent symptoms. Biological studies point to irregularities in dopamine transmission, as well as structural and functional differences in the brain, including enlarged ventricles and reduced gray matter. Genetics strongly influence risk, but environmental stress, prenatal factors, and early trauma may also contribute. Despite the severity, schizophrenia is not associated with a single defining outcome. Some individuals adapt with support and treatment, maintaining a degree of stability, while others face more disabling forms. The disorder remains one of the most studied and debated conditions in psychiatry, with many aspects still unexplained. Panic disorder. Panic disorder is a condition where sudden episodes of intense fear strike without clear warning. These episodes, called panic attacks, peak within minutes and bring strong physical and psychological symptoms. The heart may race, breathing becomes shallow, chest pain appears, and dizziness or tingling sensations spread through the body. Many describe the experience as feeling trapped or unable to escape. One defining feature is the fear of the attacks themselves. After the first episode, people often worry constantly about when the next one will occur. This anticipation can be as distressing as the attack, creating a cycle of anxiety. Some avoid public places, travel, or even leaving home, fearing that a new episode will strike in an unsafe environment. Panic disorder can overlap with other conditions. Agoraphobia frequently develops when individuals begin avoiding situations where escape feels difficult. Depression and generalized anxiety are also common companions. Because the symptoms often resemble heart disease or respiratory problems, many first seek medical help in emergency rooms before receiving a psychological diagnosis. The average age of onset is late adolescence to early adulthood. Episodes can be triggered by stress, physical exertion, or even occur during sleep. Some individuals experience only a handful of attacks in their lifetime, while others live with frequent, debilitating episodes. Biological studies show irregular activity in brain regions that regulate fear and bodily signals, especially the amygdala and brainstem. Genetic predisposition plays a role, and heightened sensitivity to bodily changes, such as increased heartbeat, can set off a chain reaction leading to a full panic attack. OCD. Obsessive-compulsive disorder is marked by two main elements: obsessions and compulsions. Obsessions are intrusive thoughts, images, or urges that appear repeatedly and feel uncontrollable. Compulsions are repetitive actions or rituals performed to reduce the distress caused by those thoughts. Together, they form cycles that can dominate daily life. Obsessions often focus on themes such as contamination, order, harm, or taboo ideas. A person may feel certain that their hands are dirty, even when clean, or fear that a door is unlocked despite repeated checking. These thoughts are recognized as irrational, but resisting them creates growing anxiety. Compulsions can be visible behaviors like washing, checking, or arranging objects. They may also be internal actions, such as repeating words mentally or counting to a certain number. The relief these rituals bring is temporary, and soon the obsession returns, restarting the cycle. This pattern makes OCD one of the most time-consuming mental disorders, with some individuals spending hours each day on their rituals. Research links OCD to overactivity in brain circuits connecting the frontal cortex, striatum, and thalamus, areas that regulate decision-making and habit formation. Serotonin regulation also appears altered. Genetic influence is strong, and early infections or autoimmune responses have been proposed as possible triggers in some cases. The disorder varies in intensity. Some individuals live with mild rituals that remain manageable, while others experience severe interference with work, relationships, and daily functioning. Unusual cases include compulsions with no clear logic, such as touching objects a specific number of times, or fearing harm unless a ritual is completed exactly. Seasonal affective disorder. Seasonal affective disorder, often shortened to SAD, is a form of depression that follows a recurring seasonal pattern. The most common type appears in late autumn or winter, when daylight decreases and lifts during spring or summer. Less often, the opposite pattern occurs, with symptoms worsening in the warm months. Typical signs mirror those of depression: persistent low mood, loss of interest, reduced energy, difficulty concentrating, and changes in sleep or appetite. In winter SAD, oversleeping and craving high carbohydrate foods are common. People may describe it as a heavy fatigue that makes even simple tasks difficult. In the less frequent summer SAD, insomnia, agitation, and loss of appetite appear instead. The condition is linked to changes in circadian rhythms, the body's internal clock that responds to light and darkness. Reduced sunlight in winter lowers levels of serotonin, a neurotransmitter connected to mood, and disrupts the production of melatonin, which regulates sleep. Brain imaging also shows altered activity in areas controlling hormone release and mood regulation. SAD is more prevalent at higher latitudes, where daylight hours are shorter in winter. For example, rates are higher in Northern Europe and Canada compared to equatorial regions. Women are diagnosed more often than men, and symptoms usually start between young adulthood and middle age. Family history of depression or bipolar disorder can increase risk. Unusual cases stand out, such as individuals who experience clear seasonal mood shifts for decades, with symptoms returning almost on the same date each year. Others report that weather alone, long periods of rain or overcast skies, can trigger episodes similar to those caused by seasonal light cycles. Postpartum depression. Postpartum depression is a mood disorder that occurs after childbirth. Unlike the short-lived baby blues, which affect many mothers for a few days, postpartum depression can last for weeks or months and brings more severe symptoms. These include persistent sadness, loss of interest, exhaustion, feelings of guilt, and difficulty bonding with the newborn. The condition does not only affect mood, it can interfere with concentration, memory, and decision-making. Physical complaints such as disrupted sleep, appetite changes, and low energy are also frequent. Some mothers describe a sense of emotional numbness, as if detached from their surroundings. Hormonal shifts after pregnancy are considered a key factor, with sudden drops in estrogen and progesterone influencing brain chemistry. Genetics, history of depression, Stressful life events and lack of social support also increase risk. Brain studies show altered activity in regions connected to emotion and maternal behavior, including the amygdala and prefrontal cortex. Postpartum depression can appear any time within the first year after birth, though it most often begins within the first few weeks. In some cases, symptoms emerge gradually and are mistaken for normal tiredness or stress, delaying recognition. The severity ranges from mild but persistent low mood to significant impairment that disrupts family life. Fathers and partners are not immune. Though less common, cases of postpartum depression in men have been recorded, often linked to stress, sleep disruption, and the major life changes of parenthood. This highlights that the condition is not solely biological, but shaped by psychological and social context as well. Cultural records show that the phenomenon is not new. Historical medical texts mention cases of prolonged melancholy in mothers, though it was poorly understood and often hidden. Today, it is recognized as a distinct disorder, separating it from both normal adjustment and other forms of depression. Alcoholism. Alcoholism, also called alcohol use disorder, is a condition where control over drinking is lost, leading to repeated use despite negative consequences. It is defined by craving, tolerance, and withdrawal symptoms when alcohol is reduced or stopped. Over time, the brain and body adapt to constant exposure, making it difficult to function without drinking. The effects appear gradually. Early stages involve frequent use, social reliance on alcohol, and inability to limit intake. As the disorder progresses, physical dependence develops. Shaking hands, sweating, and irritability may occur after even short periods without alcohol. In severe cases, sudden withdrawal can trigger seizures or delirium. Alcoholism impacts nearly every organ system. The liver is most affected, with fatty liver, hepatitis, and cirrhosis being common outcomes. Long-term use damages the heart, pancreas, and nervous system, while also weakening the immune response. Brain changes include reduced volume in areas tied to memory and decision-making, explaining cognitive decline in heavy drinkers. The condition is not uniform. Some individuals drink steadily every day, while others binge in cycles of excess, followed by abstinence. Cultural and social factors strongly influence patterns. In societies where alcohol is deeply integrated into rituals or daily life, recognition of the problem often comes late. Genetics increase vulnerability, with certain variations in enzymes that process alcohol making dependence more likely. Psychological conditions such as depression and anxiety are common co-occurrences, each reinforcing the other. Research also shows altered dopamine activity in reward pathways of the brain, making alcohol particularly reinforcing for those at risk. Unusual syndromes are connected with chronic alcohol use. Wernicke-Korsakoff syndrome, caused by vitamin B1 deficiency, leads to confusion, memory gaps, and hallucinations. In some rare cases, individuals report blackouts where hours or days are forgotten entirely, despite active behavior during that time. Alcoholism remains one of the most studied mental and behavioral disorders because it sits at the intersection of biology, psychology, and culture. It shows how a legal and socially accepted substance can produce patterns of dependence as severe as those caused by any other addictive agent. Dementia. Dementia is a broad term for conditions that cause a decline in memory, reasoning, and other cognitive functions severe enough to interfere with daily life. It is not a single disease, but a group of syndromes, with Alzheimer's disease being the most common form. Others include vascular dementia, frontotemporal dementia, and Lewy body dementia. The condition usually begins subtly. Early signs include forgetting recent events, misplacing objects, or struggling to find words. As it progresses, problems extend to planning, decision-making, and understanding time or place. Later stages may involve personality changes, difficulty recognizing familiar people, and loss of independence in daily activities. Biological studies show progressive damage to brain cells and networks. In Alzheimer's disease, abnormal protein deposits known as amyloid plaques and tau tangles disrupt communication between neurons. In vascular dementia, strokes or reduced blood flow damage brain tissue. Each type has distinct patterns, but the outcome is a gradual breakdown of cognitive function. Dementia is strongly linked to age, though it is not considered a normal part of aging. Cases in younger adults, called early onset dementia, are rare but highlight the role of genetics. Mutations in certain genes can trigger rapid decline beginning in middle age. Behavioral and psychological symptoms are common. Agitation, hallucinations, delusions, or sleep disturbances may appear as the disorder advances. Some individuals develop compulsive behaviors, while others lose interest in surroundings altogether. These changes often place heavy emotional and practical strain on families. There are also unusual and less common forms. Semantic dementia erases knowledge of words and meanings while preserving speech fluency. Prosopagnosia, or face blindness, can develop in some cases, where recognition of familiar faces becomes impossible. These rare variants illustrate how dementia can target specific cognitive functions depending on the brain regions affected. Cultural records of dementia-like states exist in historical texts described as senility or dotage. Today, modern medicine separates these from ordinary aging, recognizing dementia as a clinical condition with many subtypes, each reflecting different pathways of brain decline. PTSD. Post-traumatic stress disorder develops after exposure to events that overwhelm the body and mind's ability to cope. It can appear in soldiers, survivors of accidents, disasters, or violence, but also after less visible forms of trauma. The hallmark is that the event continues to intrude long after it is over. One of the most recognizable features is re-experiencing. Flashbacks, nightmares, or sudden intrusive memories pull the person back into the moment as if it is happening again. These episodes are often triggered by sounds, smells, or places linked to the trauma. Another core symptom is avoidance. Individuals may stay away from people, conversations, or environments that remind them of the event. At the same time, hyperarousal develops, a state of constant vigilance with irritability, insomnia, exaggerated startle reflex, and difficulty relaxing. Emotional numbness and detachment from others can also appear. Brain research shows differences in the amygdala, hippocampus, and prefrontal cortex. The amygdala becomes overactive, heightening fear responses, while the hippocampus, important for distinguishing past from present, often shrinks in size. This explains why memories can feel as immediate as current reality. PTSD is not uniform. In some, symptoms begin immediately, while in others, they remain dormant for months or years before emerging. Certain individuals experience dissociative subtypes, where they feel detached from their own body or surroundings during episodes. Others show strong physical symptoms such as chronic pain or gastrointestinal issues, even in the absence of injury. History records earlier names for similar conditions. In the First World War, it was called shell shock, while in later conflicts it became known as combat fatigue. Only in the late 20th century did psychiatry formally recognize PTSD as a distinct disorder, extending it beyond the battlefield to all forms of trauma. The condition demonstrates how memory, stress, and survival systems can malfunction, leaving the mind caught between past and present, with the body reacting as if danger never ended. Alzheimer's disease. Alzheimer's disease is the most common cause of dementia, responsible for around 2/3 of cases. It is a progressive neurodegenerative disorder that slowly erodes memory, reasoning, and behavior. Early signs often appear as subtle forgetfulness, such as misplacing objects or repeating questions. Over time, language skills weaken, problem-solving declines, and recognition of familiar people or places may fade. At the biological level, Alzheimer's is marked by two abnormalities in the brain: amyloid plaques and tau tangles. Plaques are clumps of a protein that build up between nerve cells, while tangles form inside neurons, twisting and disrupting their structure. Both interfere with communication between brain cells and eventually lead to widespread cell death. Brain imaging and autopsy studies show shrinking in areas critical for memory, particularly the hippocampus. The progression unfolds in stages. Mild Alzheimer's may involve short-term memory problems, but little else. Moderate stages bring confusion, difficulty managing daily tasks, and changes in personality, such as agitation or withdrawal. Severe stages leave the person unable to communicate clearly, recognize close relatives, or perform basic self-care. This decline typically stretches over years, often more than a decade. Genetics plays a major role. Early onset Alzheimer's, which begins before age 65, is rare but linked to mutations in specific genes. The more common late-onset form has a strong association with the APOE epsilon 4 gene variant, though carrying it does not guarantee development of the disease. Environmental factors, cardiovascular health, and lifestyle may also influence risk. Unusual symptoms sometimes occur. Some individuals develop posterior cortical atrophy, a variant where visual processing is most affected, leading to difficulty reading, recognizing objects, or judging space. Others show a logopenic variant where language and word retrieval are impaired earlier than memory. These rare forms highlight that Alzheimer's is not identical in every case. Historical descriptions of conditions resembling Alzheimer's appear centuries ago, but the disease was formally identified in 1906 by German psychiatrist Alois Alzheimer. He observed the characteristic plaques and tangles in the brain of a woman who suffered from severe memory loss and confusion. His discovery set the foundation for modern understanding of neurodegenerative disorders. Today, Alzheimer's remains incurable, though research continues into slowing its progression. The condition illustrates how microscopic changes in proteins can lead to large-scale loss of identity, memory, and independence over time. Insomnia. Insomnia is a sleep disorder where falling asleep, staying asleep, or achieving restorative sleep becomes persistently difficult. Unlike occasional sleepless nights, insomnia lasts for weeks or months, affecting energy, concentration, and mood during the day. Some individuals cannot fall asleep for hours, while others wake frequently or rise far too early without being able to return to rest. There are several recognized forms. Acute insomnia appears for a short period, often triggered by stress, illness, or environmental changes, and then resolves. Chronic insomnia persists at least 3 nights per week for more than 3 months. Sleep onset insomnia refers to difficulty beginning sleep, while sleep maintenance insomnia involves repeated awakenings or early morning rising. The effects extend beyond fatigue. Concentration and memory decline, irritability increases, and reaction times slow. Long-term insomnia is linked with higher risk of accidents, reduced immune function, and metabolic disturbances. Some individuals report a paradoxical experience called sleep state misperception. They feel they barely slept, even when brain recordings show hours of rest. Biological studies show irregularities in the balance of wake-promoting and sleep-promoting brain systems. Overactivity of the hypothalamus and stress-related hormones, such as cortisol, can keep the brain in a state of alertness at night. Genetics and disruptions of circadian rhythms also contribute. Environmental factors, noise, light, shift work, or jet lag frequently worsen symptoms. Unusual subtypes exist. Fatal familial insomnia is an extremely rare genetic disorder in which progressive loss of sleep eventually leads to severe neurological decline. Another is paradoxical insomnia, where subjective sleep time is drastically underestimated. These rare conditions show the wide spectrum hidden behind the single label of insomnia. Historical records note sleeplessness as a torment described in medical texts, diaries, and literature. Some ancient remedies involved herbs, rhythmic sounds, or controlled breathing. Despite centuries of observation, modern science still debates the exact mechanisms behind chronic insomnia, making it one of the most studied but least fully explained sleep disorders. Bulimia nervosa. Bulimia nervosa is an eating disorder defined by cycles of binge eating followed by compensatory behaviors intended to prevent weight gain. During a binge, large amounts of food are consumed in a short time, often accompanied by a sense of loss of control. Afterward, individuals may induce vomiting, misuse laxatives, fast, or engage in excessive exercise. The cycle is usually secretive, carried out in private and hidden from others. Feelings of shame, guilt, and fear of being discovered are common. Unlike anorexia, people with bulimia often maintain body weight within or close to the normal range, which makes the condition less visible to outsiders. Medical complications are serious. Frequent vomiting erodes tooth enamel, damages the esophagus, and causes electrolyte imbalances that affect heart rhythm. Chronic laxative misuse can lead to digestive system damage. In severe cases, dehydration and mineral loss can be life-threatening. Bulimia often co-occurs with mood and anxiety disorders. Obsessive concerns with body shape and weight are typical, but emotional distress, low self-esteem, and difficulty managing stress play equally important roles. Triggers for binge episodes may include negative emotions, interpersonal conflict, or strict dieting. Research shows irregularities in brain circuits controlling reward and impulse regulation, especially involving serotonin and dopamine. Family and twin studies suggest a genetic contribution, though cultural pressure and media ideals of body image strongly influence how the disorder develops. Unusual cases have been documented in medical literature. Individuals who binge on non-traditional or even non-food substances, or those whose cycles occur dozens of times per day. Another striking feature is the long delay many experience before seeking treatment, sometimes years, because the disorder can remain hidden despite severe health consequences. Historical accounts suggest that behaviors resembling bulimia were described centuries ago, though not recognized as a medical condition. Only in the late 20th century was it classified as a distinct eating disorder, separating it from both anorexia and simple overeating. Psychosis. Psychosis is a state in which an individual loses contact with shared reality. It is not a disorder on its own, but a syndrome that appears in conditions such as schizophrenia, bipolar disorder, severe depression, or substance-related problems. The hallmark features are hallucinations, delusions, and disorganized thought. Hallucinations can affect any sense. Auditory hallucinations, especially hearing voices, are the most common. Visual hallucinations may involve shadows, flashes of light, or detailed figures. Less frequent are tactile, olfactory, or gustatory hallucinations, where sensations of touch, smell, or taste appear without external cause. Delusions are fixed false beliefs that resist correction. They may involve persecution, reference, believing neutral events carry hidden messages, grandeur, or bizarre scenarios disconnected from reality. In some cases, delusions become systematized, forming elaborate personal belief structures that dominate daily life. Disorganized thought is reflected in speech. People may jump abruptly between unrelated topics, invent new words, or string phrases together without clear logic. Behavior can also become unpredictable, ranging from agitation to catatonia, where movement and response are minimal. Psychosis often develops gradually. Early warning signs include social withdrawal, unusual ideas, reduced emotional expression, and difficulty concentrating. An acute psychotic episode may follow, lasting days or weeks. Some individuals experience only one episode in their lifetime, while others have recurrent or chronic patterns. Biological studies reveal changes in dopamine transmission, structural differences in cortical and subcortical regions, and altered connectivity between brain networks. Genetics strongly influence risk, but environmental triggers such as trauma, sleep deprivation, or substance use can precipitate episodes. Unusual subtypes exist. Brief psychotic disorder resolves within a month. Postpartum psychosis appears shortly after childbirth, with sudden onset of hallucinations and delusions. Cultural variations also shape presentation. The themes of delusions often reflect local beliefs, from spirits and curses to technology and surveillance. Medical literature records descriptions of psychotic states as far back as antiquity, often interpreted through religious or supernatural frameworks. Today, psychosis is understood as a clinical syndrome, yet it continues to be one of the most striking disruptions of perception and thought known in psychiatry. Schizoaffective disorder. Schizoaffective disorder is a psychiatric condition that combines features of both schizophrenia and mood disorders. It includes psychotic symptoms such as hallucinations, delusions, and disorganized thought, alongside significant mood episodes of depression or mania. The defining feature is that psychotic symptoms persist even during times when mood symptoms are absent. Two main types are recognized. The depressive type is marked by long periods of low mood, hopelessness, and reduced energy, while the bipolar type alternates between depression and manic states. During mania, elevated energy, rapid speech, and impulsive behavior can appear. These mood fluctuations occur alongside or independently of psychotic symptoms. The onset is usually in late adolescence or early adulthood. Early signs may include social withdrawal, unusual ideas, or erratic mood changes. Over time, episodes of psychosis and mood disturbance become more distinct, making diagnosis challenging. The condition often overlaps with schizophrenia, bipolar disorder, or major depression with psychotic features, leading to frequent misclassification. Biological research shows similarities with both schizophrenia and bipolar disorder. Dopamine and serotonin regulation appear altered, and brain imaging reveals changes in frontal and temporal regions. Family studies suggest genetic overlap between the two conditions. Environmental stress, trauma, and sleep disruption may also influence onset and severity. The disorder varies greatly in its course. Some individuals experience only a few episodes with long periods of stability, while others live with recurring cycles that impair work and social life. Unusual cases include mixed states where manic and depressive symptoms occur simultaneously, creating complex presentations. Historically, schizoaffective disorder was not clearly separated from schizophrenia or mood disorders until the mid-20th century. It remains one of the more debated diagnoses in psychiatry, with ongoing discussion about whether it is a distinct condition or part of a spectrum between psychosis and mood disorders. Borderline personality disorder. Borderline personality disorder, often abbreviated as BPD, is a condition defined by instability in emotions, relationships, self-image, and behavior. The central pattern is rapid shifts between extremes: intense closeness and sudden withdrawal, confidence followed by deep insecurity, calm moments replaced by anger or despair. These changes are often triggered by small events, making daily life unpredictable. One of the most recognized features is fear of abandonment. Even minor signs of separation, a delayed reply, a canceled meeting, can trigger strong reactions, including panic, anger, or feelings of emptiness. Relationships are often described as all or nothing, moving quickly from idealization to disappointment. Emotional intensity is another hallmark. People with BPD often experience mood swings that last hours or days, unlike the longer episodes seen in bipolar disorder. Anger outbursts, deep sadness, or sudden anxiety can appear without clear warning. This instability makes it difficult to maintain steady work, friendships, or family ties. Self-image is fragile and shifting. Individuals may change goals, values, or sense of identity suddenly. Some report feeling like they do not know who they truly are. Impulsive behaviors are common. Reckless spending, risky sexual behavior, binge eating, or substance misuse may occur in attempts to cope with overwhelming feelings. Psychological research points to heightened sensitivity of the brain's emotional regulation systems, particularly the amygdala, combined with reduced control from the prefrontal cortex. Childhood trauma, unstable family environments, and genetic vulnerability are frequent in case histories, though not universal. Unusual symptoms sometimes appear. Episodes of dissociation, feeling unreal, detached, or outside one's body, can accompany stress. Some individuals also report transient psychotic-like experiences, such as hearing voices or developing paranoid thoughts during crises. These features blur the line between personality disorders and psychotic disorders. The history of BPD is complex. It was first described in the mid-20th century as a condition on the border between neurosis and psychosis, which gave rise to its name. Since then, psychiatry has refined the concept, but debates continue about whether BPD is a single disorder or part of a broader spectrum of emotional dysregulation. Cases vary widely. Some live with persistent difficulties, while others achieve long-term stability through therapy and structured support. The diversity of presentations makes borderline personality disorder one of the most studied and discussed personality conditions in modern psychiatry. Anorexia nervosa. Anorexia nervosa is an eating disorder defined by restricted food intake, intense fear of weight gain, and a distorted body image. Despite being underweight, individuals often see themselves as overweight or focus on minor imperfections in their appearance. The condition leads to severe physical and psychological consequences, making it one of the most dangerous mental health disorders. The main feature is self-starvation. Food intake is reduced far below what the body requires, sometimes limited to only a few safe items. Weight loss becomes a central goal, reinforced by rigid rituals around eating, cutting food into small pieces, hiding meals, or exercising excessively to burn calories. Medical effects appear quickly. Low body weight disrupts hormone production, leading to missed menstrual cycles in women and reduced testosterone in men. The body begins to conserve energy, heart rate slows, blood pressure drops, and body temperature decreases, often causing constant chills. Prolonged malnutrition damages bones, weakens muscles, and thins hair and skin. Psychological symptoms are equally striking. Obsession with food dominates thought, with individuals spending hours planning meals they will not eat. Anxiety and irritability rise, and social isolation becomes common. Some develop unusual eating behaviors, such as hoarding food or preparing elaborate meals for others while refusing to eat themselves. There are two main subtypes. The restrictive type focuses on strict dieting and exercise, while the binge purge type involves cycles of overeating followed by vomiting, laxative misuse, or fasting. Both forms share the same underlying fear of weight gain and distorted body perception. Research links anorexia to changes in brain circuits regulating reward and self-control, especially involving serotonin and dopamine. Genetic studies confirm a strong heritable component, while cultural ideals of thinness and perfection amplify risk. Personality traits such as perfectionism and high self-discipline often appear long before the disorder develops. Unusual cases include individuals who maintain extremely low weight yet insist they are healthy, or those who report feeling accomplishment and even calmness when hunger is strongest. Historical records describe fasting saints and ascetics whose behaviors resemble modern anorexia, though interpreted in religious terms rather than medical ones. Anorexia nervosa remains one of the few psychiatric conditions with both high medical risk and deep cultural influence. It illustrates how the drive for control over the body can override biological survival instincts, reshaping both mind and physiology in extreme ways. Hypochondria. Hypochondria, also called illness-anxiety disorder, is a condition where a person becomes preoccupied with the belief that they are seriously ill, despite medical reassurance and absence of significant symptoms. The fear is persistent, shifting from one possible disease to another as doubts remain unresolved. The central feature is misinterpretation of normal body sensations. A mild headache may be taken as a sign of a brain tumor or a cough as evidence of lung disease. Even after medical tests return normal results, the anxiety continues. For many, the relief is only temporary before new concerns emerge. Behavior patterns include frequent doctor visits, constant checking of the body for irregularities, and compulsive searching for medical information. In contrast, some individuals avoid medical care entirely, fearing that a visit will confirm their worst expectations. Both approaches are driven by the same cycle of anxiety and reassurance. Psychological research links hypochondria to heightened sensitivity to bodily signals, combined with cognitive biases that amplify harmless sensations. Stress, past experiences with illness in the family, or exposure to medical information can intensify these tendencies. Brain studies show increased activity in regions processing threat and attention, particularly the anterior cingulate cortex and insula. The condition can be long-lasting, sometimes beginning in early adulthood and persisting for decades. It often overlaps with anxiety disorders, depression, and obsessive-compulsive tendencies. Cultural influences also shape its form. In societies where certain diseases are feared, those conditions often dominate the worries of hypochondriac patients. Unusual cases include individuals convinced of rare or even impossible illnesses, such as believing that a missing organ has failed or that an undetectable infection spreads through the body. In medical history, such cases were often dismissed as imagination, yet modern psychiatry recognizes them as part of a defined disorder. Hypochondria highlights the fragile boundary between awareness of health and overwhelming preoccupation with disease. It shows how the mind's focus on survival can turn inward, transforming ordinary sensations into sources of persistent fear. Gender dysphoria. Gender dysphoria is a condition in which there is a marked incongruence between an individual's experienced gender identity and the sex assigned at birth. The central feature is significant distress or impairment caused by this mismatch, not the identity itself. The intensity of dysphoria varies. For some, it is tied to certain situations such as using public restrooms or wearing particular clothing. For others, it is constant and affects nearly every aspect of life. In children, early signs may include a strong preference for roles, clothing, or activities associated with another gender, along with rejection of those linked to their assigned sex. In adolescents and adults, dysphoria often becomes more pronounced as secondary sex characteristics develop, leading to discomfort with the body, voice, or appearance. Many report a persistent sense of living in a role that does not reflect their true identity. The distress can extend beyond internal conflict. Social interactions, misgendering, and lack of acceptance frequently intensify symptoms. Some individuals avoid mirrors, photographs, or social activities to escape reminders of the incongruence. Others experience heightened anxiety, depression, or feelings of detachment from their body. Biological studies suggest that multiple factors may contribute, including genetics, prenatal hormone exposure, and structural or functional differences in brain regions involved in gender identity. No single explanation is definitive, and research continues to examine how biological and environmental elements interact. Cultural history shows that experiences resembling gender dysphoria are not new. Many societies have recorded individuals living outside of their assigned sex roles, sometimes accepted, sometimes marginalized. Modern psychiatry introduced the formal term gender dysphoria to emphasize the distress component, distinguishing it from simple variation in gender identity. Unusual cases have been documented, such as individuals who report dysphoria focused only on specific body parts. For example, discomfort with voice or chest, but not with overall identity. Others describe fluctuating intensity, where periods of relative comfort alternate with strong episodes of distress. These variations illustrate that gender dysphoria is not uniform, but exists along a wide spectrum. The condition continues to be studied in both clinical and cultural contexts, reflecting the complex interaction of biology, identity, and society in shaping human experience. Narcolepsy. Narcolepsy is a chronic neurological disorder that disrupts the brain's ability to regulate sleep-wake cycles. Its most recognized symptom is excessive daytime sleepiness, where individuals suddenly fall asleep in inappropriate situations, during conversations, meals, or even while walking. These sleep episodes are brief but overwhelming, often described as impossible to resist. A distinctive feature is cataplexy, a sudden loss of muscle tone triggered by strong emotions such as laughter, surprise, or anger. During cataplexy, the person remains conscious but may collapse, drop objects, or lose control of facial muscles. This symptom is unique to narcolepsy with cataplexy and reflects the intrusion of rapid eye movement (REM) sleep processes into waking life. Other manifestations include sleep paralysis, a temporary inability to move or speak when falling asleep or waking up, and hypnagogic hallucinations, vivid dreamlike experiences that occur at the edge of sleep. These phenomena blur the boundary between dreaming and wakefulness, reinforcing the sense that the disorder erases normal divisions between states of consciousness. Biological research identifies loss of hypocretin, orexin, neurons in the hypothalamus as a key factor. Hypocretin regulates arousal and stabilizes transitions between sleep and wake. In narcolepsy, these cells are damaged or absent, possibly due to autoimmune processes, though genetics and environmental triggers also play roles. Brain scans confirm abnormalities in sleep architecture, with REM sleep appearing unusually quickly after sleep onset. The condition typically begins in adolescence or early adulthood. For many, symptoms are misinterpreted as laziness, depression, or epilepsy, delaying recognition for years. Once identified, narcolepsy is managed but not cured, requiring structured routines, stimulant medications, or antidepressants that reduce cataplexy. Rare and unusual cases are documented. Some individuals experience continuous fragmented sleep at night, paired with dozens of daytime naps, while others report cataplexy so mild it appears only as a slight jaw drop or eye weakness. There are also records of status cataplecticus, an extreme but rare state where cataplexy attacks occur repeatedly for hours. Historical accounts suggest that unexplained sleeping fits were recorded long before narcolepsy was formally named in the late 19th century. Today, it remains one of the most striking sleep disorders, where the mechanisms of dreaming and waking collide in daily life. Binge eating disorder. Binge eating disorder is an eating disorder characterized by recurrent episodes of consuming unusually large amounts of food in a short period of time, accompanied by a sense of loss of control. Unlike bulimia nervosa, binge eating disorder is not followed by regular purging behaviors such as vomiting or excessive exercise. Instead, the food remains in the body, often leading to weight gain and related health problems. During an episode, individuals may eat rapidly, far beyond the point of fullness, and often in secret. Feelings of shame, guilt, or disgust typically follow. The episodes are not occasional overeating, but occur regularly, sometimes multiple times a week, and are difficult to resist once the urge arises. The disorder affects both physical and mental health. Physically, it increases the risk of obesity, type 2 diabetes, heart disease, and joint problems. Psychologically, it is strongly associated with anxiety, depression, and low self-esteem. Many describe a cycle. Emotional distress triggers binge eating, which then worsens distress, reinforcing the behavior. Research indicates differences in the brain's reward system, particularly in dopamine pathways that process pleasure and motivation. Impulse control mechanisms in the prefrontal cortex also appear less active, which may explain the sudden inability to stop eating despite awareness of the consequences. Genetics, childhood adversity, and cultural pressure surrounding body image contribute as additional risk factors. Unusual cases have been reported in medical literature. Some individuals describe food blackouts, where they realize afterward that large amounts of food were consumed without clear memory of the act. Others report binging focused on very specific foods, repeating the same patterns daily. These rare variations highlight the diversity of the disorder's presentation. Historically, binge eating disorder was only formally recognized in psychiatric classifications in the late 20th and early 21st centuries. Before that, it was often grouped with bulimia or obesity without distinction. Today it is recognized as the most common eating disorder, affecting men as well as women across all age groups. Pica. Pica is an eating disorder in which individuals repeatedly consume substances that are not considered food. The behavior persists for at least a month and goes beyond cultural or developmental practices, such as children mouthing objects. Substances most often ingested include dirt, clay, paper, chalk, soap, starch, hair, or ice. In some cases, far more unusual items appear, such as glass, metal, or plastic. The condition is seen in both children and adults. In pregnancy, cravings for non-food substances have been described for centuries, sometimes linked to nutritional deficiencies. In children with developmental disorders, pica may continue long after the age when exploratory eating normally stops. Among adults, it can be associated with stress, cultural traditions, or psychiatric conditions. Medical complications vary depending on the substances consumed. Eating soil may introduce parasites or toxins, while stones or metal objects can cause intestinal blockages. Paint or plaster carries the risk of lead poisoning. Even apparently harmless substances like ice can damage teeth when consumed compulsively. Psychological theories suggest multiple pathways. Some cases are linked to deficiencies in iron or zinc, where cravings disappear once the deficiency is corrected. Others appear connected to sensory stimulation, the texture or taste of non-food items providing comfort. In psychiatric contexts, pica can occur alongside autism spectrum disorder, schizophrenia, or intellectual disability. Unusual and extreme reports exist. Medical literature describes cases where individuals consumed entire light bulbs, large quantities of paper, or hairballs so extensive they required surgical removal. Such cases, while rare, demonstrate the potential severity of the disorder. The name pica comes from the Latin word for magpie, a bird known for eating almost anything. Historical references to pica stretch back to ancient Greece and Rome, often describing pregnant women with cravings for soil or chalk. Today, it remains a rare but striking example of how human appetite can turn towards substances outside the realm of food. Imposter syndrome. Imposter syndrome is a psychological pattern in which capable and accomplished individuals believe they are frauds, fearing that their success is undeserved and will soon be exposed. Unlike ordinary self-doubt, the feeling persists even in the face of clear evidence of achievement, recognition, or competence. The core experience is the inability to internalize success. People with imposter syndrome attribute accomplishments to luck, timing, or deception rather than their own skill. Compliments or praise are often dismissed, while even minor mistakes are magnified into proof of incompetence. This creates a constant gap between external perception and internal belief. Research identifies several recurring themes. The perfectionist sets unrealistically high standards and feels like a failure when they are not met. The soloist insists on working alone, believing that asking for help exposes weakness. The expert never feels knowledgeable enough, always seeking more training or credentials. These patterns differ, but all maintain the sense of fraudulence. The phenomenon is especially common in academic and professional settings. Students may believe they were admitted to university by mistake, while professionals may think they do not deserve their role despite years of success. Surveys show high prevalence among women and minority groups, likely influenced by cultural and social pressures. Imposter syndrome is not classified as a mental disorder in diagnostic manuals, but it strongly overlaps with anxiety and depression. Its persistence can limit career progress, reduce life satisfaction, and contribute to burnout. Unusual cases have been noted. Some individuals reach extraordinary levels of recognition, publishing, awards, leadership roles, yet continue to believe their achievements are fragile illusions. Others report that even when multiple sources confirm their ability, they remain convinced of being one mistake away from exposure. The term was first introduced in 1978 by psychologists Pauline Clance and Suzanne Imes, who observed the pattern among high-achieving women. Since then, it has been recognized across genders, cultures, and professions. Historical figures such as Albert Einstein and Maya Angelou described feelings resembling imposter syndrome, showing that the experience transcends time and achievement. Although not a clinical disorder, imposter syndrome remains one of the most widespread and paradoxical psychological experiences. The stronger the evidence of success, the deeper the doubt can become. Premenstrual dysphoric disorder. Premenstrual dysphoric disorder, or PMDD, is a severe form of premenstrual syndrome that affects mood, behavior, and physical state in the days leading up to menstruation. While mild premenstrual symptoms are common, PMDD is defined by intense emotional changes that interfere with daily life. The condition appears in a cyclical pattern. Symptoms emerge during the luteal phase of the menstrual cycle, usually 1 to 2 weeks before menstruation, and fade within a few days after bleeding begins. This timing distinguishes PMDD from other mood disorders, as the pattern repeats predictably each month. Emotional symptoms are central. Irritability, sudden anger, anxiety, and deep sadness are frequently reported. Many experience mood swings that can change within hours, from calm to severe distress. Concentration difficulties, fatigue, and loss of interest in normal activities are also common. Some describe a sense of being a different person during this phase. Physical symptoms mirror those of ordinary premenstrual syndrome, but are more severe. Bloating, breast tenderness, headaches, and joint or muscle pain. Sleep problems often occur, ranging from insomnia to excessive sleep. Appetite changes are frequent, with cravings for carbohydrates or salty foods. Biological studies suggest that PMDD is not caused by abnormal hormone levels, but by heightened sensitivity to normal hormonal fluctuations, particularly changes in estrogen and progesterone. Brain imaging indicates differences in serotonin regulation during the luteal phase, which may explain the sudden shifts in mood. Historical recognition of the disorder has been limited. While premenstrual difficulties have been described for centuries, PMDD was only formally classified in psychiatric manuals in the late 20th and early 21st centuries. Its recognition remains debated in some medical circles, reflecting ongoing questions about where to draw the boundary between biological rhythm and psychiatric disorder. Unusual cases exist in which symptoms are so severe that they resemble major depression or bipolar episodes but appear only in the premenstrual period. Others report rare physical manifestations, such as temporary vision changes or skin sensitivity, linked to the hormonal cycle. These highlight the wide range of experiences grouped under PMDD. Antisocial personality disorder. Antisocial personality disorder, often abbreviated as ASPD, is a condition characterized by a long-term pattern of disregard for the rights and feelings of others. The defining traits include manipulation, deceit, impulsivity, and violation of social norms. Unlike occasional acts of rebellion, ASPD is persistent and begins early, often in childhood or adolescence, continuing into adulthood. One of the early markers is conduct disorder in childhood. Behaviors such as aggression toward people or animals, property destruction, theft, or repeated rule breaking often precede the adult form. In adulthood, these patterns evolve into chronic irresponsibility, inability to maintain employment, frequent law breaking, or disregard for safety. A key feature is lack of remorse. Individuals may justify harmful actions, blame victims, or feel little guilt after causing distress. Emotional responses often appear shallow, with charm or friendliness masking indifference. This superficial social skill sometimes allows individuals with antisocial personality disorder to manipulate situations to their advantage. Impulsivity is another common trait. Decisions are made quickly without regard for consequences, leading to reckless behavior, financial problems, or unstable relationships. Risk-taking may be frequent, and boredom tolerance is low, pushing individuals to seek constant stimulation. Biological research suggests abnormalities in brain regions involved in decision-making and emotional regulation, particularly the prefrontal cortex and amygdala. Reduced activity in these areas may contribute to poor impulse control and weak emotional responses. Genetics and early environmental factors such as neglect, abuse, or unstable family life strongly increase the risk. ASPD is not uniform. Some individuals live chaotic lives marked by frequent arrests and unstable jobs. Others appear outwardly successful, using manipulation and deception in socially acceptable or even admired ways. This variation has led to discussions about the overlap between ASPD and psychopathy, a related but not identical concept. Unusual cases are noted in clinical reports. Some individuals display extreme aggression without clear provocation, while others maintain long-term deceptive lifestyles, hiding illegal or unethical behavior for years before discovery. The condition remains one of the most studied personality disorders due to its impact on both individuals and society. Selective mutism. Selective mutism is an anxiety-related disorder where a person is capable of speech but consistently fails to speak in specific social situations. The condition most often begins in early childhood, when children speak freely at home with family, but remain silent in classrooms, playgrounds, or other public settings. The silence is not a matter of choice or defiance, but a response to overwhelming anxiety. The core pattern is situational. At home or in comfortable environments, speech may be fluent and expressive. In contrast, when faced with teachers, peers, or unfamiliar adults, words may stop completely. Some children whisper, nod, or use gestures instead of speaking, while others freeze and avoid communication altogether. Selective mutism is closely linked to social anxiety disorder. Both involve fear of negative evaluation and high sensitivity to social pressure. Physical symptoms of anxiety often appear during attempts to speak: tense posture, rigid body movements, blushing, or trembling. For many, the silence itself increases attention from others, reinforcing the cycle of fear and avoidance. The disorder can interfere strongly with development. Academic performance may decline because children cannot answer questions or participate in group activities, even when they know the material. Social relationships may be limited, as peers often misinterpret the silence as shyness or aloofness. Some children develop secondary problems such as low self-esteem or frustration with their inability to express themselves. Biological research points to a combination of genetic vulnerability, temperamental inhibition, and overactive fear responses in brain regions such as the amygdala. Environmental factors, stressful events, immigration to a new country, or family history of anxiety may trigger or worsen the condition. Unusual cases have been recorded. In some, mutism extends beyond speech to include refusal of nonverbal communication, resulting in complete withdrawal in certain environments. Others show fluctuating patterns, speaking to select individuals but remaining mute with everyone else in the same setting. Historical accounts describe children who were mistakenly labeled as stubborn, intellectually delayed, or oppositional before selective mutism was recognized as a distinct disorder in the 20th century. Today, it is understood as a rare but striking example of how anxiety can specifically block the act of speech while leaving language ability intact. Oppositional defiant disorder. Oppositional defiant disorder, or ODD, is a behavioral condition usually diagnosed in childhood. It is defined by a persistent pattern of defiant, disobedient, and hostile behavior toward authority figures such as parents, teachers, or other adults. While occasional defiance is normal in development, ODD is distinguished by its intensity, frequency, and impact on daily functioning. Typical behaviors include frequent temper outbursts, arguing with adults, deliberately refusing to follow rules, and blaming others for mistakes. Children with ODD may appear easily annoyed, resentful, or spiteful. The behavior occurs across different settings: home, school, and social environments, and lasts for at least 6 months to meet clinical criteria. The disorder is often grouped into levels of severity. Mild cases may involve symptoms confined to one setting, such as home. Moderate cases appear in at least 2 environments, while severe cases affect 3 or more. This classification reflects how widely the behavior disrupts life rather than its specific form. ODD is strongly linked to other conditions. Attention deficit hyperactivity disorder is present in many cases, and anxiety or mood disorders frequently overlap. In some children, ODD precedes more serious behavioral conditions, such as conduct disorder, though not all progress to that stage. Biological and psychological studies suggest multiple contributing factors: genetic predisposition, problems with impulse control, and differences in brain areas that regulate emotion and reward are noted. Environmental influences include inconsistent parenting, harsh discipline, or chronic family conflict. These factors interact, shaping how the disorder develops in each case. Unusual features are recorded in clinical literature. Some children display selective defiance, opposing authority only in particular contexts, such as at school, but not at home. Others exhibit paradoxical behavior, showing extreme stubbornness in minor matters while remaining compliant in significant situations. Historically, children with ODD-like behaviors were often described as stubborn or bad-tempered, without recognition of a clinical condition. The modern classification emphasizes that the behavior is not simply willful disobedience, but part of a larger psychological pattern requiring structured understanding. ODD remains one of the more debated childhood disorders, as its symptoms overlap with normal developmental phases. Its recognition, however, highlights the boundary between expected oppositional behavior and patterns that interfere with growth, learning, and relationships. Narcissistic personality disorder. Narcissistic personality disorder, or NPD, is a condition marked by a long-standing pattern of grandiosity, need for admiration, and lack of empathy. People with NPD often maintain an inflated sense of self-importance, exaggerating achievements or talents, while expecting recognition as superior regardless of actual accomplishments. The disorder extends beyond confidence, shaping the way individuals think, feel, and relate to others. A central feature is fragile self-esteem hidden behind outward confidence. Praise and admiration may temporarily reinforce a sense of worth, but criticism or perceived slights often provoke anger, shame, or withdrawal. This hypersensitivity to feedback creates unstable self-perception, shifting between superiority and vulnerability. Relationships are frequently strained. People with NPD may dominate conversations, exploit others for personal gain, or struggle to recognize the feelings and needs of those around them. At the same time, they may crave closeness and admiration, resulting in a cycle of attraction and conflict. Some relationships become characterized by manipulation, idealization of others, and sudden devaluation when expectations are not met. Clinical descriptions note 2 broad presentations. The grandiose type emphasizes arrogance, entitlement, and attention-seeking. The vulnerable type, less visible, involves insecurity, sensitivity to rejection, and hidden feelings of inadequacy. Both forms share the same underlying pattern of unstable self-image and difficulty regulating esteem. Biological and psychological studies suggest multiple influences. Brain imaging shows differences in regions involved in empathy and self-reflection, while genetic predisposition and early childhood experiences, such as inconsistent or overly critical parenting, increase risk. Cultural factors also play a role. Societies that emphasize competition and individual achievement report higher prevalence of narcissistic traits. Unusual cases illustrate the extremes. Some individuals construct elaborate false identities, inventing careers or achievements to maintain admiration. Others swing rapidly from charm to aggression in response to perceived disrespect. In rare clinical reports, narcissistic traits blend with psychotic features, producing delusions of power or uniqueness. Historically, the concept derives from the myth of Narcissus, a figure who fell in love with his own reflection. The term entered psychiatry in the early 20th century, later formalized as a personality disorder in diagnostic manuals. Its definition continues to evolve, with debate about how to separate pathological narcissism from cultural norms of confidence and self-promotion. Narcissistic personality disorder remains one of the most studied and controversial personality conditions, reflecting the tension between healthy self-regard and destructive self-absorption. It demonstrates how the human need for recognition can, in some cases, distort both identity and relationships. Dissociative identity disorder. Dissociative identity disorder, often shortened to DID, is a rare and complex psychiatric condition in which a single individual displays 2 or more distinct identities or personality states. Each identity has its own patterns of perception, memory, and behavior. Shifts between them, called switches, can occur suddenly, triggered by stress, reminders of trauma, or without clear cause. The identities, sometimes referred to as alters, may differ widely. They can vary in age, gender, voice, posture, or even handedness. Some alters hold specific memories that others do not, creating gaps in recall, a symptom known as dissociative amnesia. In daily life, this leads to lost time, unexplained actions, or finding objects and writings the primary identity does not remember creating. DID is closely linked to severe and chronic trauma, particularly during early childhood. The prevailing theory suggests that repeated traumatic experiences overwhelm the developing mind, which responds by splitting consciousness into separate identity states. These states serve as compartments to isolate overwhelming memories and emotions. Clinical reports show a wide range of experiences. Some individuals have only 2 alters, while others report dozens. Certain alters may serve distinct roles, such as protectors, caretakers, or holders of traumatic memories. Physical differences are sometimes noted, such as variations in handwriting, allergies, or visual acuity between alters, though these findings remain debated. The disorder is frequently misunderstood and has been portrayed in exaggerated ways in popular culture. While dramatic switches exist, many cases involve subtle changes in mood, demeanor, or memory rather than extreme transformations. Diagnosis is often delayed as symptoms overlap with post-traumatic stress disorder, depression, borderline personality disorder, or psychosis. Biological studies reveal differences in brain activity patterns when different identities are active. Neuroimaging has shown distinct activation in areas responsible for memory, emotion, and self-awareness, supporting the view that DID involves measurable changes rather than deliberate role-playing. Unusual cases are documented in medical literature. Some individuals develop identities that communicate internally, holding conversations or negotiating decisions. Others describe child alters with limited speech or identities with specialized skills the primary self does not possess. Rare accounts even report alters with different languages or accents. Historically, conditions resembling DID were described under names such as hysteria or multiple personality. Famous 19th and 20th century case studies brought attention to the phenomenon, though skepticism remained high. Today, DID is recognized in diagnostic systems, but debate continues about its frequency, causes, and boundaries with other disorders. The condition remains one of the most enigmatic in psychiatry, sitting at the intersection of trauma, memory, and identity itself. Body dysmorphic disorder. Body dysmorphic disorder, often abbreviated as BDD, is a mental health condition where a person becomes preoccupied with perceived flaws in their appearance. These flaws may be minor or invisible to others, but to the individual they seem highly noticeable and distressing. The focus is often on the skin, hair, nose, or other specific body parts, though any area can become the center of concern. The preoccupation is intrusive and persistent. Individuals may spend hours each day checking mirrors, grooming, comparing themselves to others, or seeking reassurance. Others avoid mirrors entirely or conceal the defect with clothing, makeup, or specific postures. Despite these efforts, anxiety and dissatisfaction remain. BDD frequently overlaps with compulsive behaviors. Repetitive skin picking, excessive use of cosmetic products, or frequent requests for dermatological or surgical procedures are common. In many cases, surgeries or treatments fail to relieve the preoccupation, and attention shifts to another body part. The condition is strongly linked to distorted self-perception. Studies suggest irregularities in how the brain processes visual details, leading to excessive focus on minor imperfections. Neuroimaging shows differences in activity within the orbitofrontal cortex and caudate nucleus, regions involved in evaluation and habit formation. Genetics and early experiences of teasing or criticism about appearance further increase risk. Social functioning is often impaired. Some individuals avoid social interactions, believing they will be judged or ridiculed. Work, school, and relationships may suffer as a result. In severe cases, people remain housebound for long periods, unable to face public settings. Unusual variations exist. Muscle dysmorphia is a subtype where individuals, often men, believe they are too small or weak despite being muscular. Others focus on symmetry, convinced that their features are uneven or misaligned. Rare reports describe preoccupation with imagined odors, overlapping with olfactory reference syndrome. Historical references suggest that concerns resembling BDD have been recorded for centuries. However, the disorder was only formally recognized in psychiatric manuals in the late 20th century. Earlier, such cases were often mistaken for vanity or obsessive-compulsive disorder. Today, body dysmorphic disorder is considered distinct, with its own diagnostic criteria. It illustrates how self-image can detach from external reality, leading to suffering that is invisible to those around the affected person. Trichotillomania. Trichotillomania, also called hair-pulling disorder, is a condition where individuals repeatedly pull out their own hair, leading to noticeable hair loss. The behavior most often targets the scalp, eyebrows, or eyelashes, though any body hair may be affected. Despite awareness of the damage, the urge is difficult to resist, and attempts to stop often fail. The act of pulling is usually preceded by tension or an uncomfortable sensation. Relief, satisfaction, or a sense of release follows once the hair is removed. Some describe the behavior as automatic, occurring without full awareness while reading, watching television, or studying. Others engage in it deliberately, seeking specific textures or sensations from the hair. The condition often begins in childhood or adolescence and may last for decades. Severity varies. Some individuals pull only a few hairs daily, while others remove large patches, creating bald spots that are difficult to conceal. Secondary behaviors sometimes develop, such as examining, chewing, or swallowing the hair, a complication that can cause gastrointestinal blockages known as trichobezoars. Trichotillomania is classified within obsessive-compulsive and related disorders. Brain imaging suggests irregularities in circuits that control habit formation, impulse regulation, and reward. Genetics play a role, with higher rates among relatives of affected individuals. Stress, boredom, or fatigue frequently intensify urges, while structured routines may reduce them. Social and psychological effects are significant. Many hide bald patches with hats, wigs, or makeup, and avoid situations where hair loss could be noticed. Feelings of shame and secrecy are common, leading to delays in seeking help. Some report that the condition consumes hours of their day, interfering with school, work, and relationships. Unusual cases are recorded in clinical literature. A few individuals pull hair not only from themselves, but from pets, dolls, or fabrics. Others describe alternating cycles, weeks of remission followed by sudden relapses with intense pulling. Rare instances involve ritualistic patterns, where hairs of a certain length, color, or texture are targeted specifically. Historical accounts suggest that hair-pulling behaviors were recognized long before modern psychiatry. References appear in ancient medical texts and in cultural descriptions of self-directed habits. The disorder was formally named in the late 19th century, with the Greek root thrix meaning hair and tillon meaning to pull. Trichotillomania remains a striking example of how the human drive for relief and control can transform into a repetitive, harmful cycle, blending physical action with psychological compulsion. Agoraphobia. Agoraphobia is an anxiety disorder defined by fear or avoidance of places where escape might be difficult or help unavailable if panic occurs. The focus is usually not on a single object, but on environments such as open spaces, crowded venues, public transport, or even leaving home alone. Symptoms include both physical and psychological reactions. Rapid heartbeat, dizziness, shortness of breath, trembling, and sweating often appear in feared settings. Mentally, people anticipate disaster, fearing collapse or loss of control. These sensations can occur before leaving home, with anxiety building long in advance. The condition often develops after repeated panic attacks in public, when fear of recurrence leads to avoidance. In other cases, it emerges gradually, beginning with discomfort in specific settings and spreading to wider restrictions. Severe forms may confine individuals to their homes, sometimes requiring accompaniment even for basic tasks. Biological and psychological research points to multiple causes. Overactivity in fear processing circuits of the brain, combined with heightened sensitivity to internal bodily signals, makes ordinary sensations like a racing heart feel threatening. Genetics and early experiences of trauma or stress increase risk, while avoidance behaviors reinforce the cycle of fear. Unusual cases exist. Some people show selective agoraphobia, avoiding only buses or markets but functioning elsewhere. Others rely heavily on safety behaviors, such as always sitting near exits, carrying medication, or insisting on a companion, which reduce anxiety but strengthen long-term dependence. Historically, similar fears were described long before psychiatry gave them a clinical name in the 20th century. Today, agoraphobia is recognized as a distinct anxiety disorder that demonstrates how ordinary spaces can gradually become charged with overwhelming fear. Complex post-traumatic stress disorder. Complex post-traumatic stress disorder, often shortened to CPTSD, develops after prolonged or repeated trauma rather than a single overwhelming event. It is commonly associated with experiences such as childhood abuse, captivity, or long-term exposure to violence or neglect. While PTSD and CPTSD share core features, the complex form extends beyond flashbacks and hypervigilance to include broader disturbances in self-concept and relationships. The core symptoms of PTSD remain intrusive memories, nightmares, avoidance of reminders, and constant alertness. In CPTSD, these are joined by additional features. One is emotional dysregulation, intense mood swings, sudden outbursts of anger, or episodes of numbness. Another is negative self-perception, deep feelings of shame, guilt, or worthlessness that persist even outside of traumatic reminders. Relationship difficulties are also central. Individuals may struggle to trust, fear abandonment, or form unhealthy attachments. Social withdrawal is frequent, while others engage in self-sacrifice or people-pleasing as a way to prevent conflict. Identity itself can feel fragmented, with some describing a sense of disconnection from who they are. Biological studies reveal similar changes to those seen in PTSD, hyperactivity of the amygdala, and reduced volume of the hippocampus, but in more pronounced or long-lasting forms. Long-term trauma appears to reshape stress response systems, leaving the body and brain in a constant state of readiness. CPTSD is often mistaken for borderline personality disorder, depression, or dissociative disorders, as overlapping features exist. The distinction lies in the origin. Ongoing trauma, especially during formative years, creates a pattern of symptoms that differ from single-incident PTSD. Unusual reports include cases where individuals experience vivid internal voices tied to traumatic figures, or strong physical reactions such as pain or nausea when confronted with reminders. Others describe fragmented memory sequences, where entire periods of childhood seem missing or inaccessible. The term gained wider use in the late 20th century to highlight the unique aftermath of long-term trauma. While debate continues about whether it should stand apart from PTSD in diagnostic manuals, it is increasingly recognized as a distinct condition, reflecting how repeated exposure can alter not only memory, but the structure of identity itself. Dysgraphia. Dysgraphia is a learning disorder that affects the ability to write. It is not caused by laziness or lack of intelligence, but by differences in how the brain processes language, fine motor skills, and spatial organization. The condition can appear in children learning to write or in adults following brain injury or neurological illness. The most visible feature is difficulty with handwriting. Letters may be irregular in size, poorly spaced, reversed, or inconsistent. Writing can be slow and physically tiring, with individuals often gripping the pen too tightly or pressing excessively hard on the page. Some describe pain or cramping in the hand after only a short period of writing. Dysgraphia affects more than penmanship. Spelling errors are frequent, even with familiar words. Sentences may lack structure, punctuation may be inconsistent, and written output is often shorter than spoken expression. In school, children with dysgraphia may understand material well but struggle to demonstrate knowledge on paper. There are several recognized types. Motor dysgraphia involves problems with fine motor control, leading to clumsy or labored writing. Spatial dysgraphia affects the ability to plan the placement of words and letters on a page. Linguistic dysgraphia disrupts the ability to translate thoughts into written language, creating incoherent or fragmented sentences. Some individuals show a combination of these types. Neuroimaging studies point to irregular activity in regions of the brain that link language and motor coordination, particularly in the parietal lobe and frontal areas. Dysgraphia often overlaps with other learning disorders such as dyslexia and dyscalculia, as well as attention deficit hyperactivity disorder. These combinations can make diagnosis more complex. Unusual cases are reported in medical literature. Some individuals can write fluently on a keyboard but not with a pen, showing that the disorder is tied specifically to handwriting. Others produce legible writing only at unusual angles or speeds, suggesting that small changes in motor control can reduce symptoms. Acquired dysgraphia in adults may affect only certain languages or alphabets, highlighting the role of learned neural pathways. Historically, writing difficulties were often attributed to poor instruction or lack of effort. The recognition of dysgraphia as a distinct disorder emphasizes that writing is a complex skill, requiring precise coordination of cognitive and motor systems. Today, it is understood as one of the lesser-known but impactful learning differences, shaping how individuals communicate knowledge in written form. Exploding head syndrome. Exploding head syndrome is a parasomnia, or sleep-related phenomenon, in which individuals experience sudden loud noises or explosive sensations inside their head as they are falling asleep or waking up. Despite the name, no physical damage occurs. The sounds are vivid, often described as gunshots, cymbals, thunderclaps, or electrical bursts, and may be accompanied by flashes of light or a sense of shock. Episodes are brief but intense. They can jolt a person awake with fear, sometimes causing rapid heartbeat, sweating, or muscle jerks. Unlike nightmares, exploding head syndrome does not involve complex dream content or imagery. The defining feature is the sudden internal noise, which feels real but has no external source. The condition is considered harmless, but can be distressing, especially when episodes are frequent. Some people experience it only once or twice in a lifetime, while others report clusters of episodes over weeks or months. For a minority, the fear of recurrence itself leads to insomnia or heightened anxiety around sleep. Research into the causes remains limited. Theories suggest a delay or misfiring in the brain's sensory shutdown process as it transitions into sleep. Normally, the nervous system reduces responsiveness during this stage, but in exploding head syndrome, auditory pathways may activate abnormally, creating the illusion of sound. Another theory links it to brief disruptions in calcium channels or temporal lobe activity. Stress, fatigue, and irregular sleep schedules appear to increase the likelihood of episodes. Unusual features have been recorded. Some individuals report a sense of presence in the room during an episode, or vibrations running through the body. Others describe simultaneous flashes of light or geometric patterns, blurring the line between auditory and visual hallucinations. Rarely, episodes occur multiple times in a single night, leading sufferers to believe they are experiencing seizures or medical emergencies, though clinical tests reveal no such conditions. Historical accounts suggest that experiences resembling exploding head syndrome were described long before the modern term was introduced in the 1980s. References to loud noises in the head during sleep appear in older medical texts, though often dismissed as imagination. The condition remains little known, even among clinicians, contributing to underreporting and misdiagnosis. Exploding head syndrome illustrates how fragile the transition between waking and sleeping can be, and how sensory systems may briefly misfire, producing experiences as startling as they are harmless. Dyscalculia. Dyscalculia is a learning disorder that affects the ability to understand numbers and mathematical concepts. It is sometimes described as the numerical counterpart of dyslexia, though the two conditions are distinct. Individuals with dyscalculia may have average or above average intelligence, but face persistent difficulties with basic arithmetic, number sense, and spatial reasoning. The most common feature is trouble grasping the meaning of numbers. Simple tasks like comparing quantities, telling time, or understanding money can become challenging. Multiplication tables, fractions, and word problems may remain difficult even after years of practice. Some struggle to remember mathematical procedures, while others cannot apply them consistently. Dyscalculia appears in different forms. Developmental dyscalculia is present from childhood, affecting learning from the start. Acquired dyscalculia arises later in life after brain injury or neurological illness, usually involving the parietal lobe, which processes numerical information. Symptoms can range from mild calculation errors to complete inability to perform everyday math-related tasks. Cognitive studies show that people with dyscalculia often have difficulty with subitizing, the ability to instantly recognize small quantities without counting. Working memory limitations also contribute, making it hard to keep track of steps in multi-stage problems. Neuroimaging reveals reduced activity in the intraparietal sulcus, a brain region critical for numerical understanding. The condition often co-occurs with other learning disorders, such as dyslexia or ADHD. In classrooms, this overlap can mask its presence, with struggles in reading or attention drawing more notice. As a result, dyscalculia is thought to be underdiagnosed, leaving many without recognition or support for their specific difficulties. Unusual cases have been reported. Some individuals can handle complex reasoning in other subjects, yet remain unable to reliably add or subtract single-digit numbers. Others compensate with memorized strategies, like using finger counting into adulthood or avoiding situations where math is required. In acquired forms, patients may lose previously strong mathematical skills while retaining other cognitive abilities. Historically, difficulties with numbers were often attributed to poor education or lack of effort. Only in the late 20th century did researchers begin to define dyscalculia as a distinct neurological condition. Today, it is recognized as an independent learning disorder, highlighting how the brain's handling of numbers can be uniquely impaired, separate from language or general intelligence. Shell shock. Shell shock is a historical term used during the First World War to describe psychological and physical symptoms experienced by soldiers exposed to prolonged combat. At the time, it was thought to result from the physical impact of exploding shells on the nervous system. However, many cases occurred without direct exposure to blasts, leading doctors to suspect psychological origins as well. Symptoms were varied. Some soldiers developed tremors, paralysis, or loss of speech without physical injury. Others suffered nightmares, insomnia, heightened startle responses, or sudden panic attacks. Memory loss and emotional numbness were also reported. These symptoms often appeared suddenly, sometimes in the middle of battle, sometimes weeks later. The scale was unprecedented. By 1916, tens of thousands of cases had been recorded. Military hospitals filled with soldiers unable to return to the front, though many were initially accused of cowardice or malingering. Treatments ranged from rest and psychotherapy to harsh methods such as electric shocks, reflecting limited understanding of the condition. Medical debates emerged. Some doctors argued that shell shock was caused by microscopic brain damage from pressure waves, while others believed it was primarily psychological trauma. Both perspectives contain truth. Modern research shows that combat stress can cause lasting psychological injury, while blast exposure can also produce subtle neurological damage. Unusual manifestations were documented. Some soldiers went blind or deaf despite no physical damage to eyes or ears. Others developed uncontrollable tics, mutism, or states of apparent stupor where they remained motionless for hours. These dramatic presentations made shell shock one of the most visible disorders of the war. The legacy of shell shock shaped modern psychiatry. After the war, the term gradually disappeared, replaced by diagnoses such as combat stress reaction and later post-traumatic stress disorder. Historical accounts of shell shock remain an early record of how extreme stress and trauma can disrupt both body and mind, long before the mechanisms were fully understood. Pyromania. Pyromania is an impulse control disorder in which a person feels a strong, repeated urge to deliberately set fires. Unlike arson, which may be driven by financial gain, revenge, or crime, pyromania involves fire setting for personal tension relief or fascination. The act is not done for external motives, but to satisfy an internal compulsion. The cycle usually follows a recognizable pattern. A buildup of tension or restlessness precedes the act. The individual may think obsessively about fire, flames, or burning materials. Setting the fire brings immediate relief or excitement, often accompanied by fascination with watching the blaze. Afterward, guilt may appear, but the cycle eventually repeats. Pyromania is rare compared to other impulse disorders. Most people who set fires do so for practical or antisocial reasons, not because of psychological compulsion. True cases of pyromania are typically diagnosed when fire setting is repeated, impulsive, and disconnected from clear external benefit. Research suggests links with abnormalities in impulse regulation and reward circuits of the brain. Some cases occur alongside mood disorders, substance use, or personality disorders. Childhood histories of fascination with fire, lack of supervision, or early traumatic experiences are frequently noted. Behavioral traits often include collecting lighters or matches, spending time near fire stations, or showing unusual interest in news reports about fires. Some individuals return to watch the destruction caused by their own actions. Others keep secret rituals, igniting small objects in private rather than large destructive fires. Unusual cases have been documented. Medical literature describes individuals who set dozens or even hundreds of fires without clear motive. In rare reports, people experienced dissociative states during the act, later claiming little memory of what they had done. There are also accounts of fire setting driven by symbolic meanings, such as purification or release, blurring the line between compulsion and belief. Historically, fire setting has long been recognized as both a crime and a psychological phenomenon. Ancient legal codes punished arson severely, but by the 19th century, psychiatry began to describe compulsive fire setting as a disorder rather than simple criminal behavior. Today, pyromania is classified as a distinct but uncommon impulse control disorder, highlighting how basic human fascination with fire can, in some cases, become uncontrollable and destructive. Kleptomania. Kleptomania is an impulse control disorder marked by the repeated urge to steal items that are not needed for personal use or financial value. Unlike ordinary theft, which has a clear motive, kleptomania involves compulsive behavior driven by inner tension and relief. The stolen objects are often inexpensive or useless, and many are discarded, hoarded, or secretly returned. The cycle begins with a rising sense of anxiety or internal pressure. Stealing temporarily relieves this tension, creating a brief feeling of satisfaction or calm. Soon after, guilt and shame usually appear, but the urge returns, leading to repetition. This cycle distinguishes kleptomania from planned or opportunistic theft. Psychological studies suggest that kleptomania shares features with obsessive-compulsive disorder and behavioral addictions. Brain research points to irregularities in regions linked to decision-making and impulse control, particularly the prefrontal cortex. Neurochemical factors also play a role, with dopamine release reinforcing the act of stealing as a source of reward. The condition is rare, estimated to occur in less than 1% of the population. It is more frequently reported among women and often emerges in late adolescence or early adulthood. Kleptomania commonly co-occurs with mood disorders, substance abuse, and anxiety conditions, making diagnosis complex. Unusual cases have been documented in clinical literature. Some individuals steal the same type of item repeatedly, such as books, clothing, or food, regardless of need. Others report amnesia-like states during theft, later recalling little of the act itself. Rare instances describe individuals who compulsively steal from family members, despite knowing discovery is almost certain. Historically, kleptomania was first described in the 19th century, at a time when courts and physicians debated whether compulsive theft should be seen as crime or illness. Early writings often portrayed it as a disorder of wealthy women who stole trivial goods, though modern research shows it can affect any social group. Today, kleptomania is recognized as a psychiatric condition rather than simple delinquency. Its presence in medical classifications underscores the difference between deliberate theft and compulsive stealing, revealing how impulses can override rational judgment even in the absence of material gain. Madonna whore complex. The Madonna whore complex is a psychological pattern in which an individual divides potential partners into two categories: the pure and virtuous figure, associated with respect and affection, and the sexual and desirable figure, associated with lust but not long-term attachment. This split makes it difficult to combine intimacy and desire within the same relationship. The concept was first described by Sigmund Freud in the early 20th century. He observed that some men idealized women they admired but could not feel attraction toward them, while directing sexual desire only toward women they devalued. Though originally framed in male-female terms, later research suggests that the dynamic can occur in any gender or relationship. At the core is a defense mechanism. By separating purity from desire, the individual avoids internal conflict between affection and sexuality. However, this division often leads to dissatisfaction, unstable relationships, or inability to maintain both closeness and passion with one partner. The complex can manifest in different ways. Some people place their long-term partner on a pedestal, treating them as untouchable or overly fragile, while seeking fulfillment elsewhere. Others cycle between admiration and contempt toward the same person, producing alternating patterns of distance and closeness. Psychological theories link the complex to early experiences. Over-idealization of a parent, strict cultural or religious norms, or unresolved conflicts about sexuality may contribute. It is also associated with certain personality disorders, where rigid thinking patterns reinforce the split. Unusual cases appear in clinical literature. Some individuals report difficulty sustaining attraction once a partner is perceived as emotionally important, leading to repeated breakups or affairs. Others experience intrusive guilt during intimacy, as if violating a boundary of respect. These variations highlight the different ways the split can shape behavior. Historically, literature and art have long reflected similar themes. Characters are portrayed as either saintly figures of devotion or as seductresses, rarely both. The formal term Madonna whore complex gave a clinical label to this cultural pattern, which continues to influence relationship psychology today. Schizoid personality disorder. Schizoid personality disorder, or SPD, is a condition defined by a long-standing pattern of detachment from social relationships and a limited range of emotional expression. Unlike social anxiety, which involves fear of judgment, schizoid detachment reflects genuine indifference to social interaction. Individuals with SPD often prefer solitary activities and show little desire for close friendships or romantic involvement. The emotional style is typically flat and reserved. People with SPD rarely display strong feelings, either positive or negative, and may appear indifferent to praise or criticism. Daily routines often revolve around solitary work, hobbies, or intellectual pursuits. Some excel in areas that require little interpersonal contact, such as technical fields, research, or artistic work done in isolation. Symptoms usually emerge in early adulthood and remain stable over time. Common features include limited interest in intimacy, preference for being alone, few pleasures from activities, and little observable change in mood. Conversations may be brief, with minimal eye contact and monotone speech, reinforcing the impression of detachment. Psychological and biological studies suggest multiple contributing factors. Family histories sometimes reveal patterns of emotional coldness or neglect. Research into brain function indicates possible differences in reward processing, making social interaction less satisfying. Genetic links with conditions such as schizophrenia have also been proposed, though SPD lacks the hallucinations or delusions seen in psychotic disorders. Unusual cases exist. Some individuals with SPD maintain functional lives but retreat almost completely outside of work, avoiding contact even with close relatives. Others report rich inner fantasy worlds that substitute for external relationships. A minority may appear sociable when required, yet remain emotionally distant, engaging in relationships only superficially. Historically, schizoid traits were described in early psychiatry as part of the schizophrenia spectrum, though later separated as a distinct personality disorder. Today, SPD is recognized as one of the least studied personality disorders, partly because individuals rarely seek treatment due to their lack of perceived distress. Schizoid personality disorder remains notable for illustrating an extreme form of social detachment, where the absence of need for closeness defines the condition as much as the lack of emotional expression. Stockholm Syndrome. Stockholm Syndrome is a psychological response in which hostages or victims form emotional bonds with their captors. The term originated after a 1973 bank robbery in Stockholm, Sweden, where hostages defended their captors after being released, surprising both police and the public. Since then, the term has been applied to a variety of situations involving captivity, abuse, or coercive control. The defining feature is paradoxical attachment. Victims may develop trust, sympathy, or even affection for those who endanger them. This response is thought to arise as a survival strategy. Aligning with the captor reduces perceived threat and increases chances of safety. Over time, this coping mechanism can blur into genuine emotional loyalty. Psychological mechanisms include identification with the aggressor, dependence for basic needs, and distorted perception under stress. Victims may focus on small acts of kindness, such as being given food or spared violence, interpreting them as signs of care. Meanwhile, the reality of coercion or danger is minimized. Stockholm Syndrome is not an official psychiatric diagnosis, but a descriptive label. It overlaps with concepts such as trauma bonding, coercive persuasion, and learned helplessness. Research suggests that the response appears in a minority of hostage or abuse cases, but its notoriety has made it a common cultural reference. Unusual cases have been reported outside of hostage situations. Victims of long-term domestic abuse, cult involvement, or human trafficking sometimes display similar attachment patterns. In rare situations, released victims refuse to testify against captors or attempt to protect them from legal consequences. Historical parallels exist. Accounts of enslaved individuals defending owners or prisoners identifying with their guards reflect similar psychological dynamics long before the modern label. Literature and folklore also contain stories where captives develop loyalty or affection toward those who hold power over them. Although debated, Stockholm Syndrome remains an enduring concept in discussions of trauma and survival. It illustrates how extreme stress can reshape attachment, creating bonds that appear illogical from the outside but function as adaptive responses in threatening environments. God complex. God complex is an informal psychological term used to describe a pattern of exaggerated self-importance, absolute certainty, and belief in one's own infallibility. A person with this mindset often assumes superiority over others, dismisses criticism, and expects unquestioned authority. Although not an official clinical diagnosis, the concept appears in discussions of personality, leadership, and pathology. The traits resemble extreme narcissism or grandiosity. Individuals may believe their opinions are unquestionably correct, resist advice, and act as though normal rules do not apply to them. In some cases, they present themselves as saviors or uniquely capable of solving problems regardless of evidence. The label God complex captures the perception of omnipotence and detachment from ordinary human limitations. Psychological theories connect the phenomenon to narcissistic personality disorder, delusional disorder, or manic states in bipolar disorder. In these contexts, the sense of superiority may stem from unstable self-esteem, distorted perception, or altered mood. However, not every display of confidence or dominance indicates a God complex. The term is often used in popular language rather than strict psychiatric classification. Unusual manifestations include belief in supernatural powers, rejection of medical or legal authority, or insistence on total control in personal and professional settings. Some historical figures have been retrospectively described as showing a God complex due to their authoritarian behavior, though such attributions remain interpretive rather than clinical. Cultural records reveal similar ideas across traditions. Ancient myths and literature portray rulers or heroes who overestimate their power and defy limits, often punished for hubris. In modern times, the expression is used to critique leaders, experts, or public figures who display unchecked confidence and disregard for accountability. The persistence of the concept reflects a broader human concern with the dangers of unchecked authority and the psychological mechanisms behind it. While not a diagnosis, God complex remains a powerful metaphor for excessive self-belief and the consequences it can bring. Histrionic personality disorder. Histrionic personality disorder, or HPD, is a condition marked by a pattern of excessive emotionality and attention-seeking. People with HPD often feel uncomfortable when they are not the center of attention and their behavior is shaped by the need to be noticed and approved of. The emotional style is dramatic, shifting quickly, and often appears shallow or exaggerated to others. Common traits include frequent use of physical appearance to draw attention, theatrical speech, and rapid mood changes. Compliments and approval may bring excitement, but criticism or lack of recognition can cause distress. Relationships often feel intense but lack depth, as the focus is on maintaining attention rather than mutual understanding. The disorder typically begins in early adulthood and remains stable over time, It is more frequently diagnosed in women, though this may reflect cultural and diagnostic biases. HPD often overlaps with other personality disorders, particularly borderline, narcissistic, and antisocial types. Depression and anxiety are also common co-occurrences, usually triggered by unmet social expectations. Psychological research suggests that HPD is shaped by both biological and environmental influences. Temperamental sensitivity, childhood experiences of inconsistent attention, and learned behaviors from family or culture contribute to its development. Neurobiological studies indicate differences in brain systems regulating reward and social response, though findings remain limited. Unusual cases appear in clinical literature. Some individuals display striking shifts in persona depending on the audience, changing speech style, body language, or even apparent interest to maximize attention. Others show extreme suggestibility, adopting the opinions of those around them in order to remain liked. Historical descriptions of dramatic and overly emotional behavior appear in medical writings as early as the 19th century, though the formal diagnosis was introduced in modern personality disorder classifications. The term histrionic comes from the Latin histrio, meaning actor, reflecting the theatrical quality of the behaviors. Histrionic personality disorder remains one of the less studied personality conditions, often overshadowed by related disorders. It illustrates the extreme form of a common human trait, the need for recognition, taken to a level that disrupts stability, relationships, and self-perception. Schizotypal personality disorder. Schizotypal personality disorder, or STPD, is a condition defined by social anxiety, unusual beliefs, and eccentric behavior. People with STPD often appear odd or peculiar to others, not only in their thoughts but also in speech, dress, and mannerisms. The disorder lies on the spectrum between personality disorders and psychotic conditions, with symptoms resembling but not reaching the severity of schizophrenia. Cognitive and perceptual distortions are central. Individuals may hold ideas of reference, believing casual events or comments relate directly to them. Superstitious or magical thinking is common, such as belief in telepathy, clairvoyance, or special powers. Some report unusual perceptual experiences, like sensing a presence when alone or hearing faint voices without full hallucinations. Social interaction is difficult. Strong discomfort with close relationships leads to isolation. Even though individuals may desire connection, conversations often appear tangential or vague, with odd phrasing or metaphors. Facial expressions, tone of voice, and gestures may seem inappropriate or mismatched, reinforcing the impression of eccentricity. Biological studies show links between STPD and schizophrenia spectrum disorders. Genetics play a role. Relatives of people with schizophrenia are more likely to display schizotypal traits. Brain imaging points to subtle differences in temporal and frontal regions, affecting language, memory, and emotional regulation. The condition usually emerges in adolescence or early adulthood and tends to remain stable throughout life. Stress may intensify symptoms, sometimes leading to short psychotic episodes under pressure. Co-occurrence with depression and anxiety is frequent, contributing to overall impairment. Unusual cases appear in clinical descriptions. Some individuals create elaborate systems of personal beliefs, combining superstition, conspiracy, and mysticism into coherent but idiosyncratic worldviews. Others maintain functional daily lives but are regarded by peers as highly eccentric, blending unusual appearance, clothing, or rituals with unconventional thinking. Historically, traits resembling schizotypal behavior were long considered eccentricity or superstition. The modern classification recognizes them as part of a clinical condition, emphasizing the overlap between personality structure and psychotic vulnerability. Schizotypal personality disorder highlights how unusual thinking and perception can persist as a stable pattern, shaping both inner experience and outward behavior. Avoidant personality disorder. Avoidant personality disorder, or AVPD, is a condition marked by extreme social inhibition, feelings of inadequacy, and hypersensitivity to criticism. Unlike ordinary shyness, the avoidance in AVPD is pervasive, affecting relationships, work, and daily activities. People with the disorder often long for connection, but withdraw out of fear of rejection or humiliation. The central features are persistent low self-esteem and expectation of disapproval. Compliments are dismissed as insincere, while neutral remarks may be interpreted as criticism. Entering new social situations brings intense anxiety, and many avoid jobs, friendships, or activities that involve close contact, even when they desire them. Behavioral patterns include reluctance to speak openly, avoidance of risks, and preference for solitary routines. Some individuals carefully monitor conversations, fearing they will say something embarrassing. Others remain silent in groups, even when they have valuable input. Over time, this reinforces isolation and strengthens negative self-perceptions. Research shows strong overlap with social anxiety disorder. Both involve fear of negative evaluation, but AVPD is broader, shaping identity and daily functioning. Genetics and temperament contribute, especially traits of behavioral inhibition in childhood. Early experiences of rejection, criticism, or neglect also increase vulnerability. Clinical studies reveal that people with AVPD often rate themselves as less socially skilled than they actually are. This distorted self-view sustains avoidance despite evidence of competence. Brain imaging suggests altered activity in regions that process threat and social signals, particularly the amygdala and prefrontal cortex. Unusual cases appear in clinical reports. Some individuals develop intricate fantasy lives as substitutes for relationships, imagining acceptance and intimacy they fear in reality. Others maintain limited contact with a single trusted person while avoiding all broader social ties. Rarely, AVPD coexists with eccentric or creative pursuits, producing individuals who contribute intellectually or artistically while remaining socially withdrawn. Historically, avoidant traits were described under labels such as inhibited personality. The modern classification as a personality disorder emphasizes the persistence and severity of the pattern. Avoidant personality disorder demonstrates how fear of rejection can dominate life, creating barriers to the very closeness that is most desired. Paranoid personality disorder. Paranoid personality disorder, or PPD, is defined by a long-standing pattern of distrust and suspicion toward others. People with PPD consistently interpret the actions of those around them as hostile, deceptive, or harmful, even when evidence does not support these conclusions. The suspicion extends to family, friends, and coworkers, making relationships tense and fragile. Core traits include constant questioning of motives, reluctance to share personal information, and readiness to perceive hidden meanings in neutral remarks. Minor slights are often magnified into deliberate insults. Compliments may be seen as manipulation, and casual mistakes by others interpreted as intentional. This vigilance produces chronic tension and irritability. Daily life is shaped by defensive behaviors. Individuals with PPD may hold grudges for long periods, test others' loyalty, or preemptively act against perceived threats. In workplaces, they may interpret routine supervision as persecution. In relationships, jealousy and accusations of betrayal are common. The condition usually begins in early adulthood and remains stable throughout life. Unlike psychotic disorders such as schizophrenia, people with PPD do not experience full hallucinations or bizarre delusions. Instead, their beliefs remain within the realm of possibility, but are exaggerated and rigid, resistant to reassurance or evidence. Biological and psychological research suggests contributions from genetics, early family environments, and cultural factors. Some studies show higher rates of suspicious thinking in families with schizophrenia, hinting at partial overlap. Childhood experiences of neglect, bullying, or inconsistent caregiving may also strengthen distrust as a defense strategy. Unusual cases appear in clinical literature. Some individuals construct elaborate conspiracy-like interpretations of ordinary events, while others isolate themselves completely, convinced that social contact is unsafe. In rare situations, suspicion escalates into aggression, particularly if the person feels cornered or falsely accused. Historical records describe traits resembling paranoia under terms such as paranoid psychopathy or chronic suspiciousness. Today, paranoid personality disorder is recognized as a distinct condition, highlighting how mistrust can dominate personality structure and distort social life without crossing into full psychosis. Obsessive-compulsive personality disorder. Obsessive-compulsive personality disorder, or OCPD, is a condition characterized by a pervasive preoccupation with order, perfectionism, and control. Unlike obsessive-compulsive disorder, OCD, which involves intrusive thoughts and repetitive rituals, OCPD centers on rigid personality traits and patterns of behavior that affect nearly all areas of life. The core features are perfectionism and inflexibility. Individuals with OCPD set extremely high standards for themselves and others. Work must be precise and flawless, often at the expense of efficiency. Tasks may be redone repeatedly until they meet personal standards, and delegation is avoided because others are seen as careless or incompetent. Control extends into daily routines. People with OCPD often plan schedules and budgets in detail, showing discomfort when unexpected events disrupt order. Hoarding of items, even those with little value, may occur out of fear they could one day be useful. Emotions are often restrained, as spontaneity feels threatening to structure. Interpersonal relationships are affected. Conversations may focus on rules, duties, or principles with little tolerance for differing opinions. Others may view individuals with OCPD as stubborn, critical, or domineering. At the same time, those with the disorder often see themselves as responsible and disciplined, unaware of how their rigidity creates conflict. Research points to multiple contributing factors. Genetic influences play a role, and traits of conscientiousness and orderliness in childhood may evolve into extreme forms. Neurobiological studies suggest altered activity in brain circuits that regulate control and decision-making, though findings remain less developed than for OCD. Unusual cases appear in clinical reports. Some individuals spend hours organizing objects into precise patterns, yet do not experience the intrusive obsessions typical of OCD. Others restrict leisure activities entirely, devoting themselves to productivity and self-imposed rules. A rare subtype emphasizes extreme morality or scrupulosity, where personal codes of conduct dominate life. Historically, rigid and perfectionistic personalities were described long before modern classifications. The recognition of OCPD as a distinct disorder highlights how traits that are socially valued, diligence, precision, reliability, can, in their extreme form, become sources of impairment and isolation. Mass hysteria. Mass hysteria, also called mass psychogenic illness, is a phenomenon where groups of people simultaneously develop similar physical or psychological symptoms without an identifiable medical cause. The symptoms spread through suggestion, observation, and social influence rather than infection or toxins. Typical signs include fainting, dizziness, nausea, rapid heartbeat, or unusual movements. Outbreaks often begin with one or two individuals showing distress, after which symptoms cascade through the group. The episodes usually occur in close-knit settings such as schools, factories, or religious gatherings where people share stress and heightened attention. Psychological explanations point to stress, fear, and collective belief. When individuals face uncertainty or pressure, the body may express anxiety through physical symptoms. Seeing others display the same reactions validates the experience, reinforcing the spread. Cultural context shapes the form. In some societies, symptoms resemble possession states, while in others they appear as medical complaints. Historical examples are well documented. In medieval Europe, outbreaks of dancing mania involved groups moving compulsively for hours or days. In the 15th to 17th centuries, convents reported episodes where nuns meowed, bit, or convulsed in unison. More recent cases include fainting spells in schools or workplaces, often traced back to anxiety rather than toxins. Unusual cases show how far the phenomenon can extend. Reports exist of mass tremors, mysterious skin rashes, or sudden collective vomiting with no physical cause. In some outbreaks, hundreds were affected, overwhelming local medical systems before the condition faded on its own. Modern psychiatry views mass hysteria as an unconscious process, distinct from deliberate imitation. The symptoms are real for those experiencing them, even if no organic disease is present. Outbreaks typically resolve once stressors are addressed or once the group disperses, illustrating the powerful role of suggestion and social environment in shaping human health. Paraphrenia. Paraphrenia is a psychiatric condition characterized by persistent delusions and hallucinations in the absence of significant cognitive decline. It resembles schizophrenia, but usually develops later in life, often after the age of 60. The defining feature is that memory, intelligence, and personality remain largely intact, distinguishing it from dementia-related psychosis. Delusions in paraphrenia are often elaborate and systematized. Common themes include persecution, conspiracy, or being watched, but grandiose beliefs, such as possessing hidden powers or secret importance, are also reported. Hallucinations, particularly auditory, may accompany the delusions, with voices commenting on or addressing the individual. Unlike in schizophrenia, emotional responses often remain stable, and social skills are relatively preserved. The condition tends to progress slowly. Early signs may involve suspiciousness or mild paranoia, gradually intensifying into fixed delusional systems. Many individuals function independently, maintaining routines and relationships, but become increasingly isolated as distrust of neighbors, relatives, or authorities deepens. Biological research suggests multiple contributing factors. Age-related changes in the brain, such as vascular damage or subtle atrophy, may interact with genetic predisposition to psychosis. Paraphrenia is more common in women, possibly due to greater longevity. Hearing loss is frequently noted, with some researchers proposing that sensory deprivation contributes to the emergence of hallucinations and paranoia. Unusual cases appear in medical literature. Some individuals construct highly detailed narratives spanning years, recording evidence of surveillance or plots against them. Others live with voices that provide companionship rather than fear, leading them to resist medical help. Rare accounts describe coexistence of paraphrenia with obsessive routines or unusual talents, preserved alongside delusional thinking. Historically, the term was introduced in the late 19th and early 20th centuries to describe forms of late-life psychosis distinct from dementia and schizophrenia. Although it has largely disappeared from modern diagnostic manuals, replaced by terms like delusional disorder or late-onset schizophrenia, paraphrenia remains in use in parts of psychiatry to highlight cases where psychosis emerges in old age without cognitive collapse. Paraphrenia illustrates how psychotic experiences can take shape in later life, separating it from both the developmental trajectory of schizophrenia and the degenerative course of dementia. It remains a reminder of the diversity of pathways through which delusions and hallucinations can arise in the human mind. Delusional disorder. Delusional disorder is a psychiatric condition defined by the presence of persistent delusions without the broad range of cognitive or emotional disturbances seen in schizophrenia. These delusions last for at least 1 month and are typically non-bizarre, meaning they involve situations that could occur in real life, such as being followed, poisoned, or deceived. Apart from the delusional beliefs, thinking and daily functioning often remain relatively intact. Several subtypes are recognized. The persecutory type is most common, marked by the belief that one is being spied on, conspired against, or harassed. The jealous type involves fixed suspicions of infidelity by a partner. The erotomanic type centers on the belief that another person, often of higher social status, is secretly in love with the patient. The somatic type includes delusions about bodily functions or illnesses, such as infestation by parasites or foul odors. Grandiose delusions involve exaggerated sense of importance, talent, or identity. Mixed types include elements of more than one theme. Unlike schizophrenia, delusional disorder does not typically involve hallucinations, disorganized speech, or severe cognitive decline. Individuals may appear rational and articulate, except when discussing their delusional beliefs. This partial preservation of functioning often allows them to maintain jobs and relationships, though the delusions themselves frequently create conflict. Biological and psychological research suggests multiple contributing factors: genetic predisposition, abnormalities in dopamine regulation, and structural changes in brain regions involved in perception and reasoning have been proposed. Environmental influences, including social isolation, immigration stress, and traumatic experiences, also appear to play a role. Unusual cases highlight the diversity of presentation. Some individuals develop highly elaborate delusional systems, meticulously recording evidence for years. Others act on their beliefs in dangerous ways, such as confronting supposed persecutors or making repeated complaints to authorities. In erotomanic cases, pursuit of the imagined admirer can lead to stalking behavior. Somatic delusions often result in repeated, unnecessary medical consultations. Historically, delusional disorder was described under terms such as paranoia or monomania, reflecting the narrow focus of symptoms. Modern psychiatry distinguishes it from schizophrenia to emphasize the preservation of personality and cognition outside of the delusional system. Delusional disorder remains challenging to study because many affected individuals do not seek psychiatric care, believing firmly in the reality of their experiences. It stands as an example of how a single false belief, if unshakable, can dominate perception and reshape a person's life. Agnosia. Agnosia is a neurological disorder in which a person loses the ability to recognize objects, sounds, shapes, or even people, despite intact senses and normal memory. Unlike blindness or deafness, agnosia is not caused by damage to sensory organs, but by injury to specific areas of the brain that process perception. It often follows stroke, head trauma, or degenerative disease affecting the occipital, temporal, or parietal lobes. There are several forms, each tied to a specific sense. Visual agnosia is the most recognized. Individuals can see but cannot identify what they are looking at. They may describe shapes or colors but fail to name the object. For example, seeing a key yet not recognizing it as a key. Auditory agnosia involves hearing sounds without understanding their meaning, such as failing to recognize a ringing phone. Tactile agnosia prevents recognition of objects by touch, even though sensation is intact. Prosopagnosia, or face blindness, is a well-known subtype. People with this condition cannot recognize familiar faces, sometimes even their own reflection. They may rely on voice, hairstyle, or clothing for identification. Another striking form is color agnosia, where individuals perceive colors but cannot assign meaning, leaving them unable to answer what color grass or the sky is. The disorder illustrates how perception and recognition are separate processes. Sensory input reaches the brain, but the connection between perception and stored knowledge is disrupted. Neuroimaging shows that different agnosias correspond to lesions in specialized brain regions, such as the fusiform gyrus for faces or the posterior temporal cortex for objects. Unusual cases appear in medical literature. Some individuals with visual agnosia can copy drawings of objects with accuracy, but still fail to identify them. Others can describe the use of an object once told its name, showing that recognition is blocked at the perceptual stage rather than erased from memory. In auditory agnosia, patients may hear a song clearly, yet be unable to recognize the melody until it is sung with words. Agnosia has been described since the late 19th century, when early neurologists identified patients who could see but not recognize. These cases helped map the brain's division of labor between sensation and interpretation. Though rare, agnosia remains one of the clearest demonstrations of how perception depends not only on the senses, but also on higher brain processes that give meaning to experience. Olfactory reference syndrome. Olfactory reference syndrome, often abbreviated as ORS, is a psychiatric condition in which individuals are convinced that they emit a foul or unpleasant body odor, despite no objective evidence. The belief is persistent and intrusive, leading to extreme distress, avoidance of social interaction, and repetitive behaviors aimed at masking the imagined smell. The preoccupation usually centers on odors such as sweat, breath, or flatulence, though some cases involve more unusual scents like chemicals or decay. The conviction is so strong that reassurance from others rarely reduces anxiety. Everyday interactions, a cough, a laugh, or someone opening a window, may be misinterpreted as signs that others are reacting to the supposed odor. Behavioral patterns often include excessive showering, frequent changes of clothing, constant use of deodorants or perfumes, and obsessive cleaning rituals. Some individuals avoid close contact, public transport, or enclosed spaces out of fear of embarrassing others. Others repeatedly seek medical or dental evaluations, convinced that doctors have overlooked a physical cause. ORS overlaps with body dysmorphic disorder, as both involve distorted perception of the self. However, in ORS, the focus is specifically on odor rather than appearance. Psychologically, it is classified as a somatic type of delusional disorder or within obsessive-compulsive related conditions, depending on severity and rigidity of belief. Research into causes is limited, but studies suggest links with social anxiety, obsessive traits, and cultural emphasis on hygiene. Neurobiological theories propose altered processing in brain circuits related to perception and self-monitoring. Stressful experiences, such as bullying or ridicule about body odor during adolescence, often appear in case histories. Unusual cases documented in clinical reports show the extremes of the disorder. Some individuals withdraw almost entirely from society, living in isolation to avoid imagined embarrassment. Others engage in dangerous cleaning practices, using harsh chemicals on skin or teeth in attempts to eliminate the odor. A few describe phantom smells, perceiving the odor themselves, which reinforces their conviction despite negative medical findings. Historically, similar complaints were described under terms such as olfactory delusional syndrome. The modern concept of ORS emerged in the 20th century, though it remains relatively unknown outside psychiatric literature. Its rarity and secrecy contribute to underdiagnosis, as many sufferers conceal their fears rather than seek help. Olfactory reference syndrome highlights how a single false belief can dominate perception and behavior, transforming ordinary social interactions into overwhelming sources of fear and self-consciousness. Excoriation disorder. Excoriation disorder, also known as skin picking disorder or dermatillomania, is a mental health condition in which individuals repeatedly pick at their own skin, leading to visible damage. The behavior goes beyond ordinary grooming. It is driven by urges that are difficult to resist, often consuming hours each day and producing significant distress or impairment. The picking usually targets the face, arms, or hands, but any area of the body may be affected. People may use fingernails, tweezers, or other objects. Some focus on small irregularities such as pimples, scabs, or perceived imperfections, while others create wounds on otherwise normal skin. The result can range from minor scratches to deep lesions that scar over time. The cycle of the disorder is distinctive. A buildup of tension or discomfort often precedes picking, followed by a sense of relief or satisfaction once the act is performed. Guilt, shame, or frustration usually comes afterward, yet the urge returns. Many describe the behavior as both automatic, occurring without awareness during activities like reading or watching television, and focused, where picking is deliberate and ritualized. Excoriation disorder is classified among obsessive-compulsive and related disorders. Neurobiological research points to irregularities in brain circuits governing impulse control, particularly those involving the striatum and prefrontal cortex. Genetic factors and co-occurring conditions, such as anxiety, depression, or obsessive-compulsive disorder, increase vulnerability. Unusual cases are noted in clinical reports. Some individuals pick symmetrically on both sides of the body, while others follow precise patterns, targeting specific shapes or textures. Rarely, individuals consume the removed skin, linking the disorder to broader compulsive or body-focused repetitive behaviors. The social impact is often severe. Many sufferers conceal scars with clothing or makeup, avoid social situations, or refuse medical care out of embarrassment. In extreme cases, infections and permanent disfigurement occur. Yet the secrecy surrounding the condition contributes to underdiagnosis, as individuals may describe their wounds as accidental. Historically, references to compulsive skin manipulation appear in medical writings from the late 19th and early 20th centuries, but excoriation disorder was only formally recognized in modern psychiatric manuals. Its classification emphasizes that the behavior is not a habit or choice, but a compulsive cycle with neurological and psychological roots. Excoriation disorder stands as a striking example of how ordinary self-care behaviors can transform into repetitive, harmful actions, reshaping both body and daily life through compulsive patterns of relief and regret. Persecution complex. Persecution complex is a psychological state in which a person believes they are being targeted, harmed, or watched by others, despite little or no supporting evidence. The belief often focuses on specific figures, neighbors, coworkers, institutions, and is maintained even when reassurances or contrary proof are given. The core pattern is persistent suspicion. Neutral remarks may be taken as insults, casual events interpreted as secret messages, and ordinary mistakes by others seen as deliberate. People may collect evidence, avoid social contact, or change routines to protect themselves. Over time, these behaviors reinforce the conviction that danger is constant. Clinically, persecution complex is related to persecutory delusions, which appear in conditions such as schizophrenia, delusional disorder, and severe mood episodes. It can also arise in milder forms, shaped by anxiety, trauma, or prolonged stress. Substance use and sensory loss, such as hearing impairment, sometimes trigger or intensify suspicious thoughts. Cultural and historical context shapes its content. In earlier centuries, fears centered on witchcraft, curses, or religious persecution. In modern times, themes often involve surveillance, technology, or government control. The underlying structure remains the same. The world is seen as hostile and personally directed against the individual. Unusual cases include highly elaborate belief systems with journals, diagrams, or long records documenting supposed conspiracies. Others involve selective paranoia, where suspicion appears only in certain environments, such as workplaces, while daily life elsewhere remains functional. Although not an official diagnosis on its own, persecution complex highlights one of the most common forms of disordered thinking. It shows how fear and mistrust, when unchecked, can grow into a fixed worldview, reshaping relationships, routines, and interpretation of reality. Napoleon complex. The term Napoleon complex describes a popular belief that shorter men are more likely to display overly assertive or domineering behavior as compensation for their stature. It is not a formal psychiatric diagnosis, but a cultural concept that links physical height with personality traits such as aggression, competitiveness, or excessive need for control. The phrase comes from the historical image of Napoleon Bonaparte, who was widely portrayed as being short and temperamental. In reality, records suggest his height was average for his time. The myth persisted, however, and the figure of Napoleon became a symbol for the idea that insecurity about physical size could drive powerful ambition and assertive behavior. The complex is usually described in behavioral terms. Alleged traits include quickness to anger, overreaction to minor challenges, competitiveness in professional or social settings, and desire for dominance in relationships. Some observers extend the label to explain risk-taking, obsession with achievement, or need for recognition. Scientific evidence is mixed. Some studies have suggested that shorter men show no greater aggression than taller men, while others report subtle differences in competitive behavior. A theory called the Napoleon complex hypothesis proposes that feelings of inferiority linked to height may influence self-esteem, but researchers caution against broad generalizations. Cultural use of the term goes far beyond individual psychology. It is often applied to political leaders, managers, or public figures whose assertiveness appears disproportionate to their physical presence. In this sense, the phrase serves more as metaphor than medical observation. Unusual cases in clinical literature describe individuals whose self-perception of being small, regardless of actual height, shaped their ambitions or anxieties. Some report chronic sensitivity to jokes or remarks about stature, leading to defensive or controlling behavior. Others pursue extreme success in careers or physical fitness as a way to counter perceived shortcomings. Historically, ideas resembling the Napoleon complex appear in literature and philosophy under the theme of compensatory behavior. The psychologist Alfred Adler, in the early 20th century, described the inferiority complex, where individuals overcompensate for perceived weaknesses. The Napoleon complex is often considered a specific cultural variation of this broader concept. Though debated, the term remains widespread in everyday language. It illustrates how society links physical characteristics to personality, whether or not scientific evidence supports the connection. The Napoleon complex persists as a cultural shorthand for the idea that insecurity, real or imagined, can drive ambitious or forceful behavior. Fatal familial insomnia. Fatal familial insomnia is an extremely rare genetic disorder that destroys the ability to sleep. It belongs to the family of prion diseases, conditions caused by abnormal proteins that damage the brain. Unlike ordinary insomnia, which comes and goes, this disorder is progressive and always fatal. The illness begins with subtle sleep problems, usually in middle age. Over time, patients lose the ability to enter deep sleep at all. Even when they appear to doze, brain activity shows they remain in a state of constant wakefulness. As the disease advances, symptoms expand. Panic attacks, rapid heart rate, hallucinations, memory loss, and loss of coordination. The cause is a mutation in the PRNP gene, which produces an abnormal prion protein. This protein accumulates in the thalamus, the brain region that regulates sleep and wakefulness. As damage spreads, normal sleep architecture collapses. Unusual details are recorded in case histories. Some patients develop vivid dreamlike states while awake, blurring reality and hallucination. Others experience emotional instability, alternating between euphoria and despair. Despite exhaustion, they cannot achieve restorative sleep, creating a state of permanent waking decline. Fatal familial insomnia has been documented in only a few dozen families worldwide. It highlights the absolute necessity of sleep for human survival, and what happens when the brain's ability to rest is irreversibly lost. Capgras delusion. Capgras delusion is a rare psychiatric disorder in which a person believes that someone close to them, often a spouse, parent, or friend, has been replaced by an identical imposter. The person looks, sounds, and behaves the same, but the patient insists they are not the real individual. The delusion usually emerges in the context of schizophrenia, dementia, brain injury, or other neurological conditions. Researchers suggest it results from a disconnect between facial recognition and emotional memory. The patient can consciously recognize a familiar face, but the automatic feeling of familiarity is absent. The mismatch is then explained through delusion. The person must be an imposter. Daily life becomes confusing and frightening. Patients may accuse loved ones of being replaced, withdraw from family, or refuse contact altogether. In some cases, they transfer affection to photographs or phone calls, situations where recognition comes without direct emotional cues, while rejecting the same person in face-to-face encounters. Unusual cases have been documented. Some patients extend the delusion to animals, believing pets have been substituted. Others apply it to places or objects, convinced their house or possessions have been replaced by perfect copies. Rarely, Capgras delusion coexists with Fregoli delusion, where strangers are believed to be a single person in disguise. The syndrome was first described in 1923 by French psychiatrist Joseph Capgras. Since then, it has been recognized as part of the broader group of misidentification delusions. Capgras delusion remains one of the most striking examples of how recognition and emotion can split apart, leading the mind to construct a bizarre but compelling explanation that the familiar has been secretly replaced. Alien hand syndrome. Alien hand syndrome is a rare neurological disorder in which one hand seems to act independently, without the person's conscious control. Patients often describe the hand as having a mind of its own. It may grasp objects, touch the face, undo buttons, or interfere with the actions of the other hand. The syndrome appears after damage to areas of the brain that coordinate movement and self-awareness, especially the corpus callosum, frontal lobe, or parietal lobe. In some cases, it follows brain surgery, such as procedures to treat epilepsy that sever the connection between hemispheres. Stroke, tumors, or neurodegenerative diseases can also trigger the condition. What makes alien hand syndrome unusual is the clear separation between intention and action. The person can see the hand moving, yet insists it is not under their control. Some feel as though it belongs to another person, others describe it as disobedient or even hostile. Despite this, the movements are purposeful, not random twitching. The hand may pick up objects, use tools, or mimic gestures. Clinical reports describe dramatic episodes. A patient's left hand might close a drawer while the right hand tries to open it. One woman repeatedly struck herself with her alien hand. Others report the hand resisting tasks, such as pushing away food the person is trying to eat. These actions occur despite the patient's awareness and attempts to stop them. Neurological research suggests the syndrome arises when motor commands are generated outside conscious control, due to disconnection between planning areas and awareness. The brain regions responsible for movements still function, but the sense of ownership over those movements is lost. This produces the eerie impression of autonomy. Alien hand syndrome has fascinated both medicine and culture because it blurs the boundary between self and body. It shows that the unity of action and will, something usually taken for granted, depends on delicate neural connections. When those connections are disrupted, the body itself can become unfamiliar, acting as if possessed by an alien force. Folie à deux, meaning madness of two, is a psychiatric phenomenon where a delusional belief is shared by two people who are closely connected. One individual, called the primary, develops a fixed delusion, and the other, the secondary, adopts the same belief through close association. The condition highlights how powerful social bonds can transmit not only emotions but also distorted realities. The delusion is usually persecutory in nature. For example, a couple may become convinced that neighbors are spying on them, or that they are being targeted by secret organizations. The primary person's conviction is so strong that the secondary, often more dependent or suggestible, comes to share it fully. The two then reinforce each other, rejecting outside explanations. Folie à deux is most common among isolated pairs such as married couples, siblings, or parent and child. Lack of external contact allows the delusion to grow unchecked. When separated, the secondary often abandons the belief, while the primary continues to hold it. This feature helps distinguish the condition from independent psychosis. Unusual cases have been recorded. Some involve folie à trois or folie en famille, where delusions spread to 3 or more people. In one report, an entire family became convinced that they were persecuted, barricading themselves in their home. Another case described sisters who shared an elaborate system of beliefs about being poisoned, despite repeated medical reassurance. The phenomenon has fascinated psychiatry since it was first described in 19th century France by Charles Lazègue and Jules Falret. It shows how delusions can be socially contagious, transmitted not through culture at large, but through the intimacy of a close relationship. Folie à deux remains a striking example of how reality itself can become a shared construction, one person's private belief gradually becoming the truth for another, binding them together in a closed world of mutual conviction. Lima syndrome. Lima syndrome is a rare psychological phenomenon in which captors or hostage takers develop sympathy, empathy, or affection toward their captives. The name comes from a 1996 hostage crisis in Lima, Peru, when members of a militant group captured hundreds of people at the Japanese ambassador's residence. Unexpectedly, many hostages were released within days, not because of pressure, but because the captors began to feel concern for their well-being. The condition is often described as the mirror image of Stockholm Syndrome, where hostages grow attached to their captors. In Lima syndrome, the reversal occurs. Those in power soften, shifting from hostility to protectiveness. The psychological mechanisms are not fully understood, but several factors are proposed. Extended interaction with hostages can humanize them, breaking down the enemy image. If the captors are young, inexperienced, or ambivalent about their mission, exposure to the vulnerability of captives may provoke guilt or compassion. In some cases, personal conversations blur the boundary between the roles of aggressor and victim. Unusual reports show that this shift can happen quickly. In some accounts, captors provided comfort, food, or blankets, apologized for fear caused, or even shared personal stories with their prisoners. A few went so far as to aid in escape or openly defy orders. Although rooted in hostage situations, Lima syndrome has been applied more broadly to describe scenarios where individuals in dominant positions grow attached to those they control. For example, abusive relationships where the abuser becomes protective, or authority figures who begin to empathize with those under their power. Unlike Stockholm syndrome, Lima syndrome is not formally recognized in psychiatry and remains more of a descriptive concept. But the documented cases highlight a paradox. In extreme circumstances, power and empathy can collide, producing bonds that undermine the very conflict that created them. Lima syndrome illustrates how fragile human roles can be. The aggressor, expected to embody hostility, may instead become entangled in compassion, turning captivity into an unexpected space for attachment and reversal of power. Somatoparaphrenia. Somatoparaphrenia is a rare neurological condition in which a person denies ownership of one of their limbs, usually an arm or a leg. The affected individual may insist the limb belongs to someone else, describe it as useless or foreign, or invent elaborate explanations for why it is attached to their body. The syndrome most often occurs after damage to the right parietal lobe, typically following a stroke. This brain region integrates sensory information and creates the sense of body ownership. When the system is disrupted, the patient may still feel and move the limb, but no longer recognize it as part of themselves. Clinical reports reveal striking details. Some patients point to their own arm in bed and claim it belongs to a family member, a hospital visitor, or even a stranger who has been left behind. Others may try to push the limb out of bed, cover it, or argue that it is attached by mistake. In extreme cases, hostility emerges. Patients may injure or attempt to remove the disowned limb. Somatoparaphrenia is distinct from simple neglect, where patients ignore one side of space or body. In this condition, the limb is actively misidentified and assigned an alternative identity. The conviction can be so strong that no amount of demonstration convinces the patient otherwise. Unusual cases include individuals who gave names and personalities to their foreign limb, or insisted it belonged to someone who was hiding in the room. Others accepted ownership only temporarily, slipping back into denial hours later. The phenomenon highlights how the sense of self is not fixed, but constructed by the brain. Even a healthy, functioning limb can feel alien when the neural circuitry of body awareness breaks down. Somatoparaphrenia remains one of the clearest examples of how identity and body are not inseparable, but rather fragile integrations of perception and belief, and how damage to a specific region of the brain can cause a person to lose the certainty that their own flesh is truly theirs. Oedipus complex. The Oedipus complex is a central concept in Freudian psychoanalysis, describing a child's unconscious desire for the parent of the opposite sex and rivalry with the parent of the same sex. The name comes from the Greek myth of Oedipus, who unknowingly killed his father and married his mother. Sigmund Freud introduced the idea in the early 20th century as part of his theory of psychosexual development. According to Freud, the complex appears during the phallic stage of development, around ages 3 to 6. A boy is said to experience unconscious attraction toward his mother and jealousy or hostility toward his father, who is seen as a rival. Freud also described a female counterpart, sometimes called the Electra complex, where a girl feels attachment to her father and competition with her mother. The theory suggests that the way children resolve this conflict shapes their personality. In Freud's view, successful resolution occurs when the child identifies with the same-sex parent, internalizing parental values and developing a stable sense of morality. Failure to resolve the conflict was thought to result in neuroses, repressed desires, or distorted relationships later in life. Criticism of the Oedipus complex is widespread. Many psychologists argue that it is culturally biased, rooted in Freud's own time and society, and not supported by empirical research. Anthropologists note that family structures vary widely, making a universal complex unlikely. Modern psychology does not recognize the Oedipus complex as a clinical condition. Despite controversy, the concept has had enormous cultural influence. It appears in literature, film, and psychoanalytic criticism as a framework for exploring family dynamics, desire, and rivalry. The language of the Oedipus complex has become shorthand for unconscious conflicts involving parents and authority figures. Unusual interpretations have expanded the idea. Some psychoanalysts describe broader Oedipal themes in adult relationships, where unresolved childhood conflicts reappear in patterns of attraction, competition, or authority struggles. Others treat the complex symbolically, as a metaphor for the tension between instinct and social rules. The Oedipus complex, whether accepted or rejected, remains one of the most enduring and debated ideas in psychology. It illustrates how myth, theory, and cultural imagination can merge into a model of the human mind that is both influential and controversial. Rumination syndrome. Rumination syndrome is a rare behavioral disorder in which recently eaten food is regurgitated from the stomach back into the mouth, then re-chewed, re-swallowed, or spit out. The process happens effortlessly and without the nausea or retching that normally accompany vomiting. Episodes often occur within minutes after meals and may repeat for hours. The condition is most often seen in children and people with developmental disabilities, but it can also appear in adolescents and adults without other medical issues. Because it looks like ordinary vomiting, it is frequently misdiagnosed as a gastrointestinal disease or an eating disorder. Unlike bulimia, however, the regurgitation is not driven by body image concerns, but by an involuntary habit-like reflex. Physiologically, rumination syndrome is believed to involve unintentional contraction of abdominal muscles that increases pressure in the stomach, forcing food back up. Over time, the body learns the pattern, and it becomes automatic. Patients often describe no discomfort, only a sense of food rising, followed by relief once regurgitation occurs. Unusual cases highlight the complexity of the disorder. Some individuals develop rituals, carefully storing or tasting the regurgitated food before discarding it. Others perform the behavior secretly, making detection difficult. In severe cases, the cycle leads to malnutrition, dental erosion, or weight loss, despite patients insisting they are not trying to purge food. Rumination syndrome has been described in medical texts since the Middle Ages, when it was sometimes mistaken for deliberate behavior or even compared to cud chewing in animals. Modern gastroenterology recognizes it as a distinct condition, though still poorly understood. The disorder shows how even something as automatic as eating can be disrupted by subtle changes in reflex and habit. Rumination syndrome blurs the line between digestive physiology and behavioral compulsion, producing a cycle where eating and regurgitation become fused into a single, involuntary pattern. Erotomania. Erotomania, also known as de Cleyre-en-Bolles syndrome, is a psychiatric condition in which an individual holds the delusional belief that another person, often of higher social status, wealth, or fame, is secretly in love with them. The belief persists despite clear evidence to the contrary and often becomes the organizing focus of the individual's life. The syndrome was first described in detail in 1921 by French psychiatrist Gaëtan de Cleyre-en-Bolles. Typical features include the conviction that subtle signals, glances, gestures, coded messages in media, are proof of secret affection. Ordinary encounters, such as passing on the street, may be reinterpreted as deliberate signs of intimacy. Erotomania most commonly occurs in the context of schizophrenia, bipolar disorder, or delusional disorder. It can also appear in people with mood disorders, especially during manic or depressive episodes. Women are reported more frequently in clinical literature, though the condition is not exclusive to one gender. Unusual cases documented in psychiatry involve individuals who sent constant letters, gifts, or messages to the supposed admirer, or who relocated cities to be closer to them. Some targeted public figures, such as actors, politicians, or doctors, convinced that barriers were only temporary obstacles to a destined union. In extreme examples, confrontation or stalking occurred, though many cases remained private and unnoticed. What distinguishes erotomania from ordinary crushes or infatuation is the fixed, delusional nature of the belief. Rejection or indifference does not weaken the conviction. Instead, it is reinterpreted as proof that the supposed admirer is hiding their true feelings due to external pressures. The condition shows how desire and perception can intertwine until reality itself is reshaped. Erotomania transforms casual signals into evidence of hidden passion, creating a closed system where the world continually confirms the imagined bond. It remains one of the most vivid examples of how delusional thought can reorganize relationships into a narrative of secret, unshakable love. Alice in Wonderland syndrome. Alice in Wonderland syndrome, AIWS, is a neurological condition that distorts perception of size, shape, time, and space. People with the syndrome may see their own body parts as shrinking or enlarging, or perceive the surrounding environment as warped. Objects may appear tiny, micropsia, or enormous, macropsia, and distances may feel exaggerated or compressed. The condition takes its name from Lewis Carroll's novel, in which the heroine's body changes size dramatically. The syndrome is most often linked to migraines, especially in children, though it can also occur in epilepsy, infections such as Epstein-Barr virus, brain lesions, or under the influence of certain substances. Episodes usually last from a few minutes to an hour, often recurring in clusters. Despite the intense distortions, vision itself is not damaged. Instead, the brain misinterprets incoming sensory information. The experience can be deeply disorienting. Patients sometimes report that their hands feel impossibly far away, or that furniture suddenly expands to fill the room. Time perception may also shift, with minutes dragging into hours or events seeming to speed up unnaturally. Some describe out-of-body sensations, as if floating or watching themselves from a distance. Unusual cases are recorded in medical literature. One child repeatedly described his parents' heads as ballooning to enormous size before returning to normal. Another adult patient insisted her body was shrinking during episodes, forcing her to check repeatedly in mirrors. In some cases, auditory distortions accompany visual changes, with sounds seeming distant, magnified, or oddly mechanical. The condition is often benign, resolving as the underlying cause is treated, but the intensity of episodes can lead to fear of losing one's mind. Because the syndrome is rare and not widely known, patients sometimes go through long periods of uncertainty before receiving an explanation. Although Alice in Wonderland syndrome is not fatal, it offers a striking glimpse into how fragile perception can be. The brain's ability to create a coherent sense of reality depends on networks that integrate vision, body schema, and time. When these networks falter, the ordinary world can suddenly transform into something uncanny, surreal, and unfamiliar, echoing the distorted landscapes of Lewis Carroll's fictional Wonderland. Anton Babinski syndrome. Anton Babinski syndrome is a rare neurological condition in which a person who is cortically blind due to brain damage rather than eye injury, denies their blindness and insists they can still see. The syndrome combines anosognosia, lack of awareness of a deficit, with confabulation, invented explanations to cover the deficit. Patients may describe visual scenes, point to objects, or navigate spaces, even though their visual cortex no longer processes images. The condition usually follows damage to the occipital lobes of the brain, most often caused by stroke, head trauma, or other lesions. The optic nerves and eyes remain intact, but the brain cannot interpret the signals. Despite this, the individual confidently asserts that vision is normal. A defining feature is confabulation. When asked to describe surroundings, patients often produce invented but detailed accounts. A blank wall may be described as a window with curtains, or a person may be imagined where no one is present. These reports are not deliberate lies, but unconscious attempts to reconcile missing sensory input with the brain's expectation of vision. Unusual cases in medical literature describe patients walking directly into obstacles while insisting they saw a clear path. One man described television programs that were not on, while another repeatedly attempted to read newspapers despite being unable to perceive the text. Some continue to argue with doctors and family members, convinced that errors are due to poor lighting or others' mistakes. The syndrome illustrates the brain's need to preserve a coherent sense of reality. Rather than accept the profound absence of vision, the mind generates plausible substitutes. Neurologists suggest that damaged feedback loops between the visual cortex and frontal regions prevent awareness of blindness, leaving confabulation to fill the gap. Anton Babinski syndrome highlights the complexity of self-awareness. It shows that knowing one's own abilities is not automatic but constructed, and when the system fails, a person can lose sight not only of the world but also of their own blindness. Charles Bonnet syndrome. Charles Bonnet syndrome is a condition in which people with significant vision loss experience vivid visual hallucinations, while remaining fully aware that what they see is not real. The syndrome was first described in the 18th century by the Swiss naturalist Charles Bonnet, who observed the phenomenon in his nearly blind grandfather. The hallucinations range from simple flashes of light or geometric patterns to detailed images of people, animals, or landscapes. Patients may see faces, buildings, or even entire scenes unfolding in front of them. Unlike psychosis, these hallucinations are not accompanied by delusions or loss of insight. Individuals usually recognize that the visions are a trick of the mind. The syndrome typically appears in people with macular degeneration, glaucoma, cataracts, or other eye diseases that reduce input to the brain. Deprived of visual signals, the brain compensates by generating its own images, similar to how phantom limb sensations occur after amputation. Neurological studies suggest hyperactivity in visual processing areas when normal input is missing. Clinical reports reveal unusual and sometimes elaborate visions. Patients describe rows of miniature figures marching across a table, faces appearing in wallpaper, or animals walking through the room. The images often appear suddenly, last for seconds or minutes, and vanish without warning. They are usually silent, although rare cases include visualized speech. The hallucinations can be disturbing, but many patients find them more strange than frightening. Because the syndrome is little known, some initially fear they are going mad, only to be relieved when they learn it is a recognized effect of vision loss. Awareness of the condition often helps reduce distress. Historically, Charles Bonnet syndrome was seen as rare, but modern research suggests it is underreported since many people with vision loss conceal their experiences. It is now recognized as relatively common among the elderly with severe eye disease. Charles Bonnet syndrome demonstrates how the brain strives to fill gaps in sensory input. When vision fails, perception does not simply fade into darkness. Instead, the mind projects its own imagery, creating a private theater of hallucinatory scenes. Reduplicative paramnesia. Reduplicative paramnesia is a rare delusional misidentification syndrome in which a person believes that a familiar place exists in two or more locations at once, or that it has been duplicated and relocated. For example, a hospital patient may insist that the ward they are lying in is actually their own home, or that the hospital itself has been secretly copied somewhere else. The syndrome is most often associated with brain damage, especially to the frontal lobes and the right hemisphere, areas involved in memory, orientation, and reality testing. It is also reported after head trauma, stroke, tumors, or an advanced dementia. Unlike simple disorientation, reduplicative paramnesia involves a fixed, elaborate conviction rather than confusion. Unusual case reports illustrate its peculiar logic. One patient believed that the hospital where he was being treated had been moved brick by brick to another city. Another insisted there were two identical versions of the same nursing home, and that staff traveled back and forth between them. In some instances, patients believed their home had been copied, and that they were living in the duplicate rather than the original. The phenomenon is closely related to other misidentification syndromes, such as Capgras delusion, believing people are imposters, and Fregoli delusion, believing strangers are one disguised person. All involve disruption of the brain's ability to integrate recognition with spatial and emotional memory. In reduplicative paramnesia, the breakdown centers on place. The surroundings look familiar, but the sense of location is fractured. Clinical observations show that the delusion often coexists with confabulation, invented stories that explain how duplication occurred. Patients may speak of buildings being transported, rebuilt, or existing in parallel locations. Attempts to correct the belief with evidence usually fail, as the conviction feels more real than contradictory facts. Historically, the term was introduced in the early 20th century by neurologist Arnold Pick, who studied patients with unusual spatial delusions. Since then, cases have remained rare but striking, offering insight into how the brain constructs a sense of place and continuity. Reduplicative paramnesia demonstrates how even the most familiar environments, homes, hospitals, streets, can be perceived as unstable and multiplied, turning ordinary surroundings into a stage for impossible geography. Subjective doubles. Subjective doubles is a rare delusional misidentification syndrome in which a person believes that they have a double. Another individual who looks identical to them but has a different personality or identity. Unlike the more familiar Capgras delusion, which focuses on others being replaced by imposters, subjective doubles centers on the self being duplicated and embodied in someone else. The syndrome was first described in the 1970s by psychiatrist George Christodoulou. Patients with this condition often claim that their double exists in the real world, sometimes living nearby, sometimes moving in secret. The double is believed to act independently, often carrying out hostile, immoral, or threatening behaviors. Subjective doubles is usually seen in the context of schizophrenia, schizoaffective disorder, or severe mood disorders with psychotic features. It has also been reported after brain injuries, particularly affecting the temporal and frontal lobes. The phenomenon reflects disruption in self-recognition systems, the brain's ability to link physical appearance with personal identity. Unusual cases described in medical literature are striking. One patient believed that an identical double was living in another city, committing crimes that would be blamed on him. Another insisted that his double had replaced him in family life, taking his role as husband and father. In a few cases, patients identified strangers as their doubles, pointing to random people and claiming they shared their appearance and identity. The delusion can produce strong emotional reactions. Some patients feel persecuted, convinced that their double is attempting to ruin their reputation. Others feel detached, as though part of their identity has split away and gained independence. In rare reports, individuals tried to confront or even attack those they believed to be their doubles. Subjective doubles overlaps with other syndromes, such as mirrored self misidentification, reduplicative paramnesia, and Capgras delusion. All highlight how fragile the sense of identity can be when recognition and self-awareness break down. Though extremely rare, subjective doubles provides a striking example of self-division. It shows how the mind can project fragments of identity outward, creating a duplicate self that seems both familiar and alien, turning one's own existence into a source of suspicion and fear. Mirrored self misidentification. Mirrored self misidentification is a rare delusional syndrome in which a person fails to recognize their own reflection in a mirror. Instead of seeing themselves, they believe the image belongs to another person, sometimes a stranger, sometimes a relative, or even an imposter. Unlike ordinary confusion or forgetfulness, this belief is fixed and resistant to correction, even when confronted with evidence. The syndrome is most often linked to neurological damage, especially affecting the right hemisphere of the brain, which plays a crucial role in self-recognition and facial processing. It frequently appears in dementia, stroke, or traumatic brain injury. Patients may retain the ability to recognize photographs of themselves, yet insist that their mirror reflection is someone else. Clinical reports reveal unusual details. Some patients greet the figure in the mirror politely, convinced they are meeting a visitor. Others become suspicious or hostile, accusing the reflection of spying or mocking them. In rare cases, individuals have attempted to talk, feed, or even fight with their reflected double. Mirrored self-misidentification is part of the broader group of delusional misidentification syndromes, which includes Capgras delusion, Fregoli delusion, and subjective doubles. What makes it unique is that the misidentified figure is not another person, but the self. The condition highlights how fragile self-awareness is when the brain regions responsible for recognition and emotional familiarity fall out of sync. Some case studies describe patients who insist the reflection is a relative, such as a sibling or child, reasoning that the similarity in appearance must be due to family ties. Others claim the reflection is an impostor planted to confuse them. Attempts to explain the concept of reflection usually fail. The patient maintains their belief with confabulations, invented explanations that preserve the delusion. Historically, mirrored self-misidentification has been noted in neurological literature since the early 20th century. Although extremely rare, it remains one of the most vivid demonstrations of how self-recognition, something most people take for granted, depends on delicate neural mechanisms. The syndrome shows how identity can fracture at its most basic level. When the brain no longer links one's own face with the sense of me, even the mirror becomes a source of strangeness, transforming the most familiar image into that of a stranger staring back. Akinetic mutism. Akinetic mutism is a rare neurological state in which a person is awake and appears alert, but does not move or speak. The eyes may follow objects, and the individual may appear to register sounds or visual cues, yet voluntary actions are absent. It is as though the body and voice are frozen, while consciousness remains dimly present. The condition is most often associated with damage to the frontal lobes, cingulate gyrus, or connections within the brainstem. Strokes, tumors, head trauma, or severe hydrocephalus have all been linked to its onset. Unlike coma, where awareness is absent, patients with akinetic mutism may open their eyes, track movement, or respond minimally, but they remain unable to initiate action or speech. Clinicians describe it as a profound disorder of motivation. The motor system is intact and language skills are preserved, but the drive to act is missing. Patients may sit motionless for hours, making only small eye movements. When prompted repeatedly, they may whisper short words, or move slightly, but without sustained effort. Unusual cases highlight the eerie nature of the syndrome. Some individuals stare silently at visitors as if aware, yet give no verbal response. Others exhibit automatic reactions, swallowing, blinking, or reflexive movements, but no purposeful activity. In rare reports, patients suddenly spoke short sentences after days of silence, only to lapse back into mutism. Neurological studies suggest that damage to circuits involving the anterior cingulate cortex disrupts the brain's initiation system. This area is crucial for linking intention with action, and when impaired, the capacity for movement and speech exists, but cannot be triggered. Historically, the condition was first described in the 1940s, often in patients with frontal lobe tumors. Since then, it has been recognized as distinct from coma, catatonia, or locked-in syndrome, though the states can appear superficially similar. Akinetic mutism illustrates how fragile the link between will and action can be. When the circuits that generate initiative are disrupted, even the simplest act, raising a hand, speaking a word, becomes impossible, leaving the body in a state of silent watchfulness. Catatonia. Catatonia is a mental and neurological state where movement, speech, and behavior change in extreme ways. A person may become completely still and silent, or, on the contrary, move constantly without clear purpose. The most recognizable form is immobility. Patients may sit or lie without speaking or reacting, sometimes holding unusual positions for hours. This is called posturing. Even when someone tries to move them, they may resist, as if their body refuses outside influence. In other cases, they suddenly copy what others do or say, repeating words, echolalia, or imitating gestures, echopraxia. There is also an opposite side of catatonia, excitement. Instead of silence and stillness, a person may pace, wave their arms, or repeat movements endlessly. These actions are not controlled or purposeful, but driven by an inner state that disconnects from normal intention. Unusual cases are striking. Some people remain frozen like statues, eyes open, not reacting even to pain. Others mirror every action of those nearby, turning into a kind of living reflection. There are cases where a patient repeats the same phrase for hours or stays silent but clearly aware of their surroundings. Doctors link catatonia to malfunctions in brain circuits that control movement and motivation. The exact mechanism is still not fully understood. What is known is that, despite its severity, catatonia often responds to treatment very quickly. Sometimes a single dose of medicine or electroconvulsive therapy can break the state within hours. Catatonia was first described in the 19th century by psychiatrist Carl Kalbaum. For many years it was considered a type of schizophrenia, but today it is recognized as a condition that can appear in many illnesses, bipolar disorder, depression, or even brain infections. Catatonia shows how fragile the connection is between the mind and the body. A person may be fully awake, but unable to move, speak, or act normally. It turns the body into something between a statue and a mirror where the usual expression of thought and will disappears. Jonah complex. The Jonah complex is a term from humanistic psychology that describes the fear of fulfilling one's own potential. It was introduced by Abraham Maslow, the psychologist best known for the hierarchy of needs. The name comes from the biblical story of Jonah, who fled from the destiny chosen for him and tried to hide from his calling. At the core of the complex is avoidance. People may sense they are capable of greater achievement, creativity, or responsibility, but withdraw when the opportunity arises. Instead of stepping forward, they hold back, fearing the consequences of growth. This fear is not of failure, but of success itself, of standing out, being noticed, or having to live up to a new standard. Maslow observed this pattern in talented individuals who repeatedly sabotage themselves. Some would procrastinate when faced with important tasks. Others would deliberately choose smaller goals or deny their abilities. In all cases, the behavior was a way to escape the anxiety that came with potential greatness. Psychologists describe the Jonah complex as a mix of fear of responsibility, fear of isolation, and fear of change. To reach one's potential means leaving behind comfort and familiarity, and confronting the possibility of rejection or envy from others. Growth requires risk, and the Jonah complex is a retreat from that risk. Unusual examples appear in case studies and biographies. Writers who abandon manuscripts at the point of success, athletes who underperform in decisive moments, or inventors who refuse to share their discoveries can all be interpreted through this lens. In each case, the person avoids the burden of standing fully in their own capability. The Jonah complex is not a formal diagnosis, but a descriptive idea. It highlights a paradox. People often fear not their weakness, but their strength. The concept remains influential in psychology, self-development, and philosophy, showing how the greatest obstacle to potential may come not from outside, but from within. The Jonah complex demonstrates that human beings are not only limited by external barriers. Sometimes the most powerful resistance comes from an inner refusal to become what one already has the capacity to be. Ganser syndrome. Ganser syndrome is a rare psychiatric condition characterized by giving approximate answers to simple questions, alongside other symptoms such as confusion, hallucinations, or altered consciousness. It was first described in the late 19th century by German psychiatrist Sigbert Ganser, who observed the phenomenon in prison inmates. Because of this origin, it has sometimes been called prison psychosis. The hallmark feature is Vorbeireden, or talking past the point. For example, when asked, "How many legs does a horse have?" a person might answer 3 or 5. The response is close to correct but clearly wrong, suggesting partial awareness mixed with disruption of normal thinking. These approximate answers are not random guesses, but follow a peculiar internal logic. Ganser syndrome often appears suddenly, usually in response to extreme stress, trauma, or confinement. In addition to approximate answers, individuals may display clouded consciousness, memory gaps, or conversion-like symptoms such as paralysis or loss of sensation without medical cause. Hallucinations, particularly vivid visual or auditory experiences, have also been reported. The syndrome is sometimes grouped under dissociative disorders, reflecting its connection to stress and altered consciousness. Some researchers classify it as factitious, meaning the symptoms may be partly produced, consciously or unconsciously, in reaction to overwhelming situations. Others view it as a distinct condition that overlaps with psychosis, dissociation, and malingering, but cannot be reduced to any single category. Unusual cases described in medical literature include sudden recovery after removal from stressful environments, or patients who exhibited symptoms only in institutional settings, but not in ordinary life. Some individuals alternate between periods of approximate answering and normal cognition within the same day. There are also reports of Ganser-like states occurring in children, though they are extremely rare. The rarity of the syndrome has made it difficult to study systematically. Many case reports emphasize its association with prisons, war, or extreme psychological pressure, environments where mental symptoms may blur with adaptive strategies for survival. This ambiguity continues to fuel debate over whether Ganser syndrome is primarily dissociative, psychotic, or partly voluntary. Despite uncertainties, Ganser syndrome remains a striking example of how the mind can generate unusual cognitive patterns under duress. The phenomenon of approximate answers, close to correct yet consistently wrong, captures the tension between awareness and disconnection that defines the condition. Cotard's syndrome. Cotard's syndrome, sometimes called the walking corpse syndrome, is a rare psychiatric condition in which individuals believe they are dead, do not exist, or have lost their internal organs, blood, or soul. First described in the late 19th century by French neurologist Jules Cotard, the syndrome remains one of the most unusual and striking delusional disorders documented in psychiatry. The central feature is nihilistic delusion. Patients may insist they are dead despite speaking and moving, or claim that their body is rotting away. Some believe that parts of themselves are missing. For example, that their heart has stopped beating or their intestines have disappeared. In severe cases, the delusion extends to the external world. People may declare that the universe has ended or that nothing exists at all. The syndrome often co-occurs with severe depression, psychotic disorders, or neurological illness. Brain imaging studies suggest abnormalities in regions associated with emotion and self-perception, particularly the parietal and frontal lobes. Damage from stroke, head trauma, or neurodegenerative disease has also been linked to Cotard-like symptoms. Behavioral consequences can be extreme. If someone believes they are already dead, they may stop eating, neglect hygiene, or avoid medical care. Some express indifference to pain or injury, convinced that physical harm cannot affect them. Others wander aimlessly, explaining that there is no reason to stay in one place when they are no longer alive. Unusual cases are well documented. One patient claimed she was dead and therefore could not freeze, walking outdoors in winter without clothing. Another insisted his body was hollow, filled only with emptiness. Rarely, patients report immortality rather than death, believing they are cursed to exist forever without function. Historically, Cotard's syndrome has appeared in diverse clinical contexts, from psychiatric hospitals to neurology wards. The condition is rare, but its vivid presentations have made it an enduring subject in medical literature and cultural references. Cotard's syndrome demonstrates how far delusional thinking can distort the basic sense of existence. It highlights the role of the brain in creating the feeling of being alive, and how disruption of this process can lead to one of the most paradoxical beliefs in psychiatry, the conviction of death within a living body. Fregoli delusion. Fregoli delusion is a rare psychiatric condition in which an individual believes that different people are in fact a single person who changes appearance or is in disguise. The name comes from Leopoldo Fregoli, an Italian actor famous for his rapid transformations on stage. The delusion typically involves the belief that this disguised person is following, persecuting, or manipulating the individual. The central feature is mistaken identity. Someone with the delusion may insist that strangers, acquaintances, or even family members are actually one familiar person adopting multiple appearances. Encounters in public spaces, meeting new faces on the street, or seeing people in shops are interpreted as proof of the disguised persecutor's presence. The condition is classified as a delusional misidentification syndrome, alongside Capgras delusion, believing familiar people are imposters, and intermetamorphosis, believing people exchange identities. Fregoli is distinguished by the idea of one person taking on many forms rather than people being replaced. Clinical reports often link Fregoli delusion to underlying neurological or psychiatric disorders. It appears in schizophrenia, mood disorders with psychotic features, and after brain injury, particularly in the right frontal and temporal lobes. Abnormalities in facial recognition pathways and memory circuits are thought to contribute, producing errors in distinguishing new faces from familiar ones. Unusual cases have been documented in medical literature. One patient believed that a famous celebrity was disguising themselves as neighbors and strangers to torment her. Another insisted that every doctor and nurse in a hospital was actually the same individual in different clothing. These accounts highlight the persistence and coherence of the delusion, despite its implausibility. Behavioral consequences can be significant. Constant suspicion leads to social withdrawal, avoidance of public spaces, or confrontation with supposed persecutors. In severe cases, individuals keep extensive notes or journals, interpreting minor coincidences as evidence of disguise. Historically, the first detailed case was described in 1927 by French psychiatrists Courbon and Fayle, who observed a woman convinced that two actresses she admired were disguising themselves as people around her. Since then, Fregoli delusion has remained rare but striking, appearing mainly in single-case reports rather than large studies. Fregoli delusion illustrates how errors in facial recognition and memory can combine with paranoia, creating a belief system in which identity itself becomes unstable. It remains one of the most unusual disruptions of self and perception recorded in psychiatry. Munchausen syndrome. Munchausen syndrome is a psychiatric condition in which individuals deliberately fabricate or induce symptoms of illness in themselves. The motivation is not material gain, such as insurance benefits, but the psychological need to assume the role of a patient and receive medical attention. The disorder was named in the 1950s after Baron von Munchausen, a German nobleman famous for exaggerated stories of his adventures. The condition is part of the spectrum of factitious disorders. Unlike malingering, where symptoms are faked for practical reasons, Munchausen involves deception aimed at fulfilling internal psychological needs. Individuals may present with dramatic, convincing symptoms, often supported by elaborate histories. They frequently seek treatment at multiple hospitals, a pattern sometimes called hospital hopping. Typical behaviors include falsifying medical records, exaggerating symptoms, or even causing injury or illness. Some inject themselves with bacteria, take drugs to provoke side effects, or tamper with laboratory samples. Because of the deliberate nature of the actions, diagnosis is challenging, requiring evidence that symptoms are intentionally produced. Clinical features often include extensive medical knowledge, eagerness for invasive tests, and resistance to psychiatric evaluation. Patients may appear cooperative at first, but become hostile when confronted with doubts about their authenticity. Many disappear from hospitals once suspicion is raised, only to reappear elsewhere with new complaints. The disorder is associated with early trauma, unstable relationships, or histories of illness in childhood. Some theories suggest that adopting the patient role provides a sense of identity or a way to gain care and sympathy that was absent earlier in life. Co-occurring personality disorders, especially borderline and antisocial types, are frequently noted. Unusual cases have been documented. Individuals have undergone dozens of surgeries without clear medical need or presented with bizarre and inconsistent symptoms that nonetheless led to extensive medical workups. Rare reports describe patients traveling internationally to continue the cycle, accumulating years of unnecessary procedures. Historically, behaviors resembling Munchausen syndrome were observed long before the term was coined, but they were often labeled as malingering or deception. The modern classification emphasizes the psychiatric dimension, recognizing the behavior as driven by psychological need rather than practical motive. Munchausen syndrome remains one of the most complex and challenging conditions in psychiatry, lying at the intersection of deception, identity, and the human need for care. It illustrates how the role of patient itself can become a powerful, even compulsive goal. Delusional parasitosis. Delusional parasitosis is a psychiatric condition in which individuals are convinced that their body is infested with parasites, insects, or other living organisms, despite no medical evidence. The belief is fixed and resistant to reassurance, often leading to repeated visits to doctors and requests for unnecessary treatments. The central symptom is the sensation of crawling, biting, or stinging on or under the skin, known as formication. These feelings are interpreted as proof of infestation. Patients may describe seeing small creatures emerging from their skin, collect samples in containers, or present debris such as lint or scabs as evidence of parasites, a behavior sometimes called the matchbox sign. Delusional parasitosis can appear as a primary disorder or secondary to other conditions. It is observed in schizophrenia, mood disorders with psychotic features, dementia, and substance-induced psychosis, especially from stimulants such as cocaine or amphetamines. Neurological illnesses and vitamin deficiencies have also been linked to similar presentations. The disorder has serious consequences. Individuals may scratch or pick at their skin to remove imagined parasites, leading to wounds, infections, or scarring. Some resort to dangerous chemical treatments, applying pesticides or industrial cleaners to the body. Social relationships suffer as sufferers withdraw, convinced that others may become contaminated, or that people doubt their experiences. Unusual cases appear frequently in medical reports. Some involve couples or families sharing the same delusion, a phenomenon known as folie à deux. Others extend the infestation beyond the body to the home, with repeated attempts to fumigate or replace furniture. In rare instances, patients describe parasites that are invisible, mechanical, or supernatural, blending psychosis with cultural or personal belief systems. Historically, descriptions of people convinced of infestation appear in medical writings from the 17th and 18th centuries. The modern psychiatric label emphasizes the delusional nature of the belief, separating it from genuine parasitic infections. Despite advances in recognition, diagnosis remains challenging, as patients often reject psychiatric explanations and insist on dermatological treatment. Delusional parasitosis stands as one of the most vivid examples of how perception and belief can distort bodily experience. The disorder merges sensation with conviction, creating a reality where infestation feels as undeniable as any physical disease. Jerusalem syndrome. Jerusalem syndrome is a rare psychological phenomenon in which visitors to the city of Jerusalem develop intense religious thoughts, delusions, or behaviors. The condition is notable because it arises specifically in connection with the location, blending personal vulnerability with the city's powerful cultural and spiritual significance. The syndrome typically begins after arrival in Jerusalem. Individuals may suddenly feel an overwhelming sense of mission, spiritual awakening, or identification with biblical figures. Some adopt ritualistic clothing, deliver sermons in public places, or attempt to reenact religious events. In many cases, the behavior appears abruptly in people with no previous psychiatric history, though others may already have underlying underlying conditions. Psychiatrists categorize the syndrome into types. One involves individuals with pre-existing mental illness, such as schizophrenia, whose delusions adapt to the religious context of Jerusalem. Another involves those with strong religious personalities but no prior diagnosis, who become overwhelmed by the city's symbolic atmosphere. A third, rarest type, emerges in people with no history of psychiatric problems, who develop sudden and temporary psychosis linked only to the experience of being in Jerusalem. Symptoms usually include anxiety, withdrawal from companions, obsessive cleanliness or purification rituals, and sudden preaching in public. Many declare that they have been chosen to deliver a divine message. Some shave their heads, wear makeshift robes, or march to holy sites while quoting scripture. Unusual cases are well documented. One man dressed entirely in white sheets and proclaimed himself a prophet at the Western Wall. Another attempted to conduct a reenactment of biblical sacrifices. Hospitals in Jerusalem have admitted tourists who believed they were King David, the Virgin Mary, or the Messiah. In most cases, the psychosis resolves after a few weeks, especially once the person leaves the city. The syndrome is not officially listed as a distinct psychiatric disorder, but is recognized in medical literature as a culturally bound form of psychosis. Researchers suggest that the city's intensity, a convergence of history, religion, and expectation, acts as a trigger for those already vulnerable to psychological stress. Jerusalem syndrome illustrates how place and culture can shape mental states, producing a condition where geography and belief combine to generate striking, if temporary, disturbances of identity and behavior. Messiah complex. Messiah complex is a psychological pattern in which a person believes they are destined to save, guide, or redeem others. It is not an official psychiatric diagnosis, but a descriptive term that appears in psychology, psychiatry, and cultural studies. The complex involves a strong conviction of special mission, often combined with feelings of moral superiority, responsibility for others, or divine selection. The central idea is identification with a savior role. People with this mindset may believe they have been chosen by God, fate, or history to deliver humanity from danger or ignorance. In less extreme forms, it can manifest as a persistent need to rescue friends, family, or even strangers, often at personal cost. In severe forms, the belief becomes delusional, with claims of being a prophet, messiah, or world leader. The complex is closely linked with grandiosity. Individuals often display confidence that resists criticism, interpreting doubts as persecution or misunderstanding. They may see ordinary setbacks as trials confirming their special role. This pattern overlaps with narcissistic personality traits and, in clinical cases, with psychotic disorders where grandiose delusions dominate. Behavioral expressions vary. Some devote themselves to activism or religious preaching, convinced their mission is divinely sanctioned. Others attempt symbolic acts of sacrifice, service, or leadership. In history, figures with strong charismatic influence have been retrospectively described as showing a messiah complex, though such claims remain interpretive rather than diagnostic. Unusual cases documented in psychiatry include individuals who believe natural disasters or wars depend on their actions, or who adopt biblical identities with full conviction. Some isolate themselves to prepare for a divine mission, while others act out in public, declaring themselves saviors. Cultural history shows that similar patterns appear worldwide. Many traditions feature prophetic or chosen figures, and modern individuals who internalize these archetypes may shape their delusions around them. The city of Jerusalem, Mecca, or other holy places often serve as backdrops for such episodes, reinforcing the sense of spiritual mission. Though not a formal diagnosis, the Messiah complex highlights how cultural narratives and personal psychology can merge, producing powerful convictions of destiny and purpose. It shows how the universal human search for meaning can, in some cases, crystallize into a fixed belief in one's own role as a redeemer. Intermetamorphosis. Intermetamorphosis is a rare psychiatric phenomenon in which an individual believes that people around them exchange identities with one another while keeping the same appearance. For example, a patient may insist that a friend has become a different person entirely, inhabiting the same body but with a new mind, intentions, and personality. The delusion combines errors of identity recognition with paranoia, often producing elaborate and distressing narratives. The condition belongs to a group of misidentification syndromes, alongside Capgras delusion, believing loved ones are imposters, and Fragoli delusion, believing one persecutor appears in many disguises. What distinguishes intermetamorphosis is the idea of identity transfer between familiar people. The body remains constant, but the internal identity is believed to change. Clinical descriptions show that the delusion often arises in schizophrenia, schizoaffective disorder, dementia, or after brain injury. lesions in the right hemisphere, particularly the temporal and frontal lobes, have been linked to such cases. Researchers suggest that abnormalities in facial recognition pathways and self-other processing may disrupt the brain's integration of appearance and identity. Symptoms can extend beyond simple belief. Patients sometimes interpret ordinary interactions as proof of identity exchange, claiming that voices, gestures, or knowledge confirm that one person has become another. These explanations may form part of larger paranoid systems, where multiple people are thought to be switching roles in order to deceive or persecute. Unusual cases in medical literature include individuals convinced that family members repeatedly swap identities, making it impossible to trust anyone at home. Others believe that authority figures, doctors, police, or supervisors, are secretly rotating through different identities to confuse them. Rarely, intermetamorphosis has been combined with violent or defensive behavior, when patients act against those they believe are imposters in disguise. Historically, the term was introduced in the mid-20th century by French psychiatrists Courbon and Tusks, who classified it alongside other identity delusions. Since then, reports remain rare, often limited to single-case studies, but they continue to highlight the phenomenon as distinct from general paranoia. Intermetamorphosis demonstrates how deeply the human brain integrates recognition and identity. When these processes fail, the most familiar people can appear as strangers in disguise, producing one of the most unsettling disruptions of perception in psychiatry. Stendhal syndrome. Stendhal syndrome is a psychosomatic condition in which individuals experience intense physical and emotional reactions when exposed to art, beauty, or historically significant places. Symptoms include rapid heartbeat, dizziness, fainting, confusion, and overwhelming feelings of awe or anxiety. The condition was named after the 19th century French writer Stendhal, who described his own overwhelming response to Renaissance art during a visit to Florence. The syndrome most often appears in museums, cathedrals, or cultural landmarks, especially in Florence, where many cases have been reported by medical staff. Visitors sometimes collapse after prolonged exposure to paintings, sculptures, or architecture, convinced they are unable to process the intensity of the experience. Doctors at Santa Maria Nuova Hospital in Florence recorded clusters of such episodes in the late 20th century, bringing the condition to wider attention. Psychologists interpret Stendhal syndrome as an interaction between personal sensitivity, cultural expectation, and situational stress. People who are deeply invested in art or spirituality may be more vulnerable. Travel fatigue, jet lag, or crowded environments can amplify the effect, pushing emotional arousal into physical symptoms. Neurobiological explanations suggest overstimulation of brain circuits that integrate emotion, perception, and autonomic response. Unusual cases are described in clinical reports. Some individuals experienced hallucinations of figures stepping out of paintings, or felt compelled to touch artworks as if drawn by magnetic force. Others became disoriented, wandering aimlessly in galleries or insisting they were part of the art itself. In a few cases, episodes evolved into temporary psychosis, requiring short hospitalization before recovery. Stendhal syndrome is not recognized as an official psychiatric diagnosis, but is regarded as a culture-bound phenomenon. Similar reactions have been reported in other locations rich in symbolism, such as Jerusalem or Mecca, suggesting that powerful cultural settings can trigger comparable responses. The Florence Association remains the most iconic, however, giving the syndrome its enduring name. Historically, reports of people fainting before art or religious relics can be found centuries before Stendhal. The modern label emphasizes the link between aesthetics and psychosomatic reaction, turning an age-old experience into a subject of medical and psychological study. Stendhal syndrome illustrates how beauty, symbolism, and cultural weight can overwhelm the senses, producing reactions that blur the line between emotion, body, and mind. Diogenes syndrome. Diogenes syndrome is a behavioral disorder characterized by extreme self-neglect, social withdrawal, and compulsive hoarding of objects or waste. The name refers to the ancient Greek philosopher Diogenes of Sinope, who lived in simplicity and rejected social norms, though the syndrome itself bears little resemblance to his philosophy. It is most commonly observed in older adults, though it can appear at any age. The main features include neglect of hygiene, refusal of medical help, and accumulation of large amounts of clutter, often mixed with garbage or spoiled food. Living spaces become unsanitary, with blocked pathways, infestations, and unsafe conditions. Despite the chaos, individuals may strongly resist attempts to clean or intervene, insisting that nothing is wrong. Psychiatric and neurological conditions often coexist. Diogenes syndrome can develop alongside dementia, depression, obsessive-compulsive traits, or frontal lobe damage. However, some cases appear in people without a clear psychiatric diagnosis, suggesting that personality and life circumstances also play roles. Social isolation, bereavement, and distrust of authority frequently precede onset. Unusual cases reported in medical literature describe individuals living in extreme neglect while maintaining intellectual or professional abilities in other areas. Some carefully hoard specific objects, newspapers, containers, clothing, while others indiscriminately accumulate any available material. A few resist contact so strongly that they barricade themselves at home, discovered only when conditions become life-threatening. The syndrome has significant consequences. Malnutrition, infections, and accidents are common, and neighbors or relatives often raise concerns when odors or pests spread beyond the home. Because of resistance to outside help, intervention is difficult, requiring coordinated medical, psychiatric, and social approaches. Historically, behaviors resembling Diogenes syndrome were described under terms such as senile squalor syndrome. The modern label emphasizes the paradox between extreme neglect and the preservation of basic survival, distinguishing it from ordinary hoarding or poverty. Diogenes syndrome remains a striking example of how withdrawal from society and neglect of self can combine into a distinct behavioral pattern, producing living conditions that appear incomprehensible from the outside, yet are persistently defended by those affected. Boanthropy. Boanthropy is a rare psychological condition in which a person believes themselves to be a cow or an ox, often behaving accordingly. The word comes from the Greek bous, ox, and anthropos, man. Historical records and scattered modern reports describe individuals who crawl on all fours, graze on grass, or imitate the sounds and movements of cattle under the conviction that they have transformed into such an animal. The phenomenon is classified among delusional misidentification and identity disorders, closely related to clinical lycanthropy, in which individuals believe they are wolves or other animals. Unlike simple role play or symbolic behavior, boanthropy involves a fixed belief or altered state of consciousness in which the person genuinely experiences themselves as non-human. The most famous historical reference appears in the Book of Daniel, where King Nebuchadnezzar is described as living like an ox, eating grass, and dwelling outdoors until his reason returned. Some scholars interpret this passage as an early description of boanthropy. In modern times, psychiatric case reports describe similar presentations, often linked to schizophrenia, psychotic depression, or neurological illness. Clinical features vary. Some patients spend hours or days imitating cattle, refusing ordinary food and insisting on eating grass. Others describe dreams or hallucinations in which they transform, followed by waking behavior consistent with the vision. In some cases, the condition occurs during acute psychosis and resolves once the episode ends. In others, the belief persists for years. Neurobiological theories suggest dysfunction in areas of the brain that mediate self-perception and body schema, particularly the temporoparietal junction. Psychological explanations emphasize the symbolic meaning of animals, with cattle representing submission, burden, or loss of autonomy. Stress, trauma, or cultural beliefs about animal spirits may shape the specific form of the delusion. Unusual cases in medical literature include individuals found living in fields, subsisting on grass and water, convinced they had become oxen. In one report, the person described tactile hallucinations of fur and horns. In others, the transformation belief appeared alongside religious themes, with patients claiming divine punishment or purification through becoming an animal. Boanthropy remains extremely rare, with most knowledge coming from isolated case studies and historical references. It demonstrates the depth of identity disruption possible in psychosis, where even the boundary between human and animal can dissolve into lived conviction. Mental illness in animals. The study of mental illness in animals examines whether non-human species can display disorders resembling those seen in people. While animals cannot describe thoughts or beliefs, their behavior and physiology suggest parallels with conditions such as anxiety, depression, compulsions, and post-traumatic stress. Research in this field comes from veterinary medicine, neuroscience, and ethology, as well as anecdotal accounts from pet owners and zookeepers. Domesticated animals, especially dogs and cats, show behaviors that closely resemble human disorders. Dogs can develop separation anxiety, pacing, howling, or destroying objects when left alone. Some lick or chew their own skin until it bleeds, a behavior compared to obsessive-compulsive disorder. Cats may compulsively groom to the point of baldness or show signs of depression after the loss of a companion. Horses develop cribbing, repetitive biting on wood, often linked to stress or boredom. Zoo animals provide further examples. Elephants deprived of social groups sometimes sway rhythmically for hours, a behavior thought to mirror human stereotypies seen in psychiatric institutions. Captive primates have been observed rocking, self-harming, or withdrawing after trauma. Chimpanzees exposed to violence in captivity have displayed symptoms likened to post-traumatic stress, including hypervigilance and avoidance. Scientific studies support these parallels, Laboratory rodents exposed to chronic stress show learned helplessness, reduced motivation, and changes in brain chemistry resembling depression. Selective breeding has created animal models for traits like impulsivity, anxiety, or compulsions used to study human disorders. Neuroimaging reveals that brain regions involved in emotion, such as the amygdala and prefrontal cortex, function similarly across mammals. Unusual cases highlight the blurred line between animal behavior and psychiatric illness. Parrots in isolation sometimes pluck out their feathers compulsively. Dolphins in captivity have been described as refusing to eat or intentionally colliding with tank walls. Even wild animals show trauma responses. Whales exposed to sonar or hunting sometimes strand themselves repeatedly, behavior some scientists interpret as stress-related. The question of whether animals truly have mental illness remains debated. Some researchers argue that human categories cannot be directly applied, while others note that the underlying biological mechanisms appear remarkably conserved. What is clear is that animals display persistent maladaptive behaviors arising from stress, trauma, or genetic vulnerability, patterns that strongly resemble human psychiatric conditions. The study of mental illness in animals underscores the continuity between human and non-human minds. It highlights how complex emotional and behavioral disturbances are not uniquely human, but part of a wider spectrum of responses across species when brain, environment, and social life fall out of balance. Phaedra complex. The Phaedra complex is a psychoanalytic term describing situations in which a stepmother develops sexual or romantic feelings toward her stepson. The name comes from Greek mythology. Phaedra, wife of King Theseus, fell in love with her stepson Hippolytus. After he rejected her, she accused him falsely, leading to his death, and later took her own life. The myth became a symbol of forbidden desire within family structures. The complex is less well known than the Oedipus or Electra complexes, but follows the same Freudian tradition of linking myth to unconscious dynamics. It reflects conflict between desire, morality, and family roles. In psychoanalytic theory, the Phaedra complex illustrates how repressed impulses can manifest in destructive ways, especially when directed toward socially forbidden relationships. Psychologists use the term broadly rather than as a clinical diagnosis. It is applied to step-family dynamics where boundaries blur, leading to tension, rivalry, or projection. In some interpretations, the complex represents the anxiety of a new partner entering an existing family, where affection and jealousy become entangled. The stepmother may unconsciously compete with the child for the father's attention, with attraction serving as a distorted expression of rivalry. Unusual cases in psychiatric literature are rare, but have been reported. Some involve step relationships where inappropriate attachment becomes obsessive, producing conflict or accusations. Others describe symbolic, rather than literal desire, with fantasies or intrusive thoughts that never translate into action. These examples highlight how the complex functions more as a framework for interpretation than a strict medical category. In cultural history, the Phaedra story has been retold in plays, novels, and films across centuries, often emphasizing the destructive power of forbidden attraction. Genre scenes 17th century tragedy Phaedra and later adaptations reinforced the link between mythology and psychological conflict. The continued use of Phaedra complex reflects how mythology provides language to describe interpersonal struggles that psychiatry does not formally classify. While not recognized as a clinical disorder, the Phaedra complex endures as a symbolic concept. It illustrates how myth, psychology, and family dynamics intersect, providing a lens to examine the tension between desire, morality, and social taboo. Truman Syndrome. Truman Syndrome is a rare psychiatric phenomenon in which individuals believe that their lives are part of a staged reality show, closely monitored by cameras and watched by an audience. The condition takes its name from The Truman Show, a film in which the protagonist unknowingly lives inside a massive television production. Since the movie's release, psychiatrists have reported cases where patients explicitly describe similar experiences. The central feature is the delusion of surveillance and performance. Patients insist that family, friends, coworkers, or strangers are actors following a script. Everyday events are interpreted as staged. Conversations, news broadcasts, or passing remarks become clues in a vast production. Many report the conviction that their movements are broadcast worldwide, with hidden cameras in homes, streets, or workplaces. Truman Syndrome is considered a modern variant of persecutory and grandiose delusions. It overlaps with schizophrenia, schizoaffective disorder, and psychotic depression, where themes of surveillance and control are common. What distinguishes it is the cultural framing, the idea of being inside a media production, reflecting contemporary anxieties about technology, celebrity, and constant observation. Clinical reports describe unusual cases. One patient traveled to New York City to confirm the existence of the television set he believed surrounded him. Another demanded entry into television studios, insisting on confronting producers of the show. Some attempt to act in ways they believe will entertain their audience, while others withdraw in paranoia, fearing humiliation before the world. The phenomenon raises questions about how culture shapes the content of delusions. In earlier centuries, individuals might have believed they were targeted by witches or spies. Today, delusions often involve television, the internet, or social media. Truman Syndrome illustrates how psychosis adapts to technological and cultural contexts, embedding itself in the metaphors of the time. Though not recognized as a formal diagnosis, the syndrome has entered psychiatric literature as a striking example of culturally specific psychosis. It demonstrates how cultural symbols, in this case mass media and surveillance, provide the framework through which disordered beliefs are constructed and maintained. Clinical lycanthropy. Clinical lycanthropy is a rare psychiatric syndrome in which an individual believes they can transform, or have already transformed, into a wolf or another animal. The name derives from the ancient concept of lycanthropy, the mythical ability to become a wolf. In psychiatry, the condition is classified as a delusional misidentification of the self, where identity and bodily perception are profoundly altered. The central feature is the conviction of metamorphosis. Some patients describe physical sensations, growing fur, lengthening teeth, or changes in body shape. Others insist that they have already taken animal form, behaving by crawling, howling, or attempting to eat raw meat. In some cases, the belief is episodic, emerging during psychotic episodes and disappearing afterward. Clinical lycanthropy usually appears alongside schizophrenia, bipolar disorder, or severe depression with psychotic features. Neurological illness, such as temporal lobe epilepsy or brain injury, has also been linked to lycanthropic delusions. Neuroimaging studies suggest abnormalities in areas of the brain responsible for body schema and self-recognition, particularly the parietal and frontal lobes. Unusual cases documented in medical literature reveal striking details. Some individuals report looking in the mirror and seeing an animal face instead of their own. Others experience tactile hallucinations, such as the feeling of claws or fangs emerging. In a few reports, patients alternated between different animals, wolves, dogs, or even snakes, showing that the delusion can extend beyond the wolf archetype. Historically, descriptions of people believing themselves to be wolves or other creatures date back centuries, often interpreted as witchcraft or possession. Medieval Europe associated such beliefs with werewolf legends, and confessions during witch trials sometimes included claims of transformation. Modern psychiatry reinterprets these accounts as likely cases of clinical lycanthropy or related psychotic conditions. Although extremely rare today, clinical lycanthropy remains significant for illustrating how psychosis can distort the most basic sense of identity. It demonstrates how cultural myths and neurological dysfunction can converge, creating a lived conviction of transformation that bridges folklore and psychiatry. Autophagia. Autophagia is a rare condition in which individuals feel compelled to bite, chew, or consume parts of their own body. It is classified as a form of self-injurious behavior, often grouped with impulse control or obsessive-compulsive spectrum disorders. Unlike ordinary habits such as nail biting, autophagia can involve severe damage, targeting fingers, lips, or other accessible areas, sometimes to the point of partial mutilation. The behavior usually begins with tension or discomfort, followed by the act of biting or chewing, and then temporary relief. Over time, the cycle becomes compulsive, reinforced by the reduction of inner stress. Some individuals describe urges that are impossible to resist, even when the behavior causes pain, infection, or permanent injury. Autophagia is often associated with other psychiatric conditions. It has been observed in schizophrenia, obsessive-compulsive disorder, autism spectrum disorder, and certain developmental disabilities. In rare cases, it appears in neurological conditions such as Lesch-Nyhan syndrome, where self-biting is a prominent feature. Substance use, stress, or psychotic episodes can intensify the urges. Unusual cases described in medical literature include individuals who chewed entire fingernails and parts of fingertips until they bled, or who repeatedly bit the inside of the mouth despite severe injury. Others targeted larger areas of flesh, requiring surgical treatment. A few reports mention people who attempted to swallow the bitten tissue, giving the behavior its name, which literally means self-eating. Historically, references to self-cannibalistic behavior appear in psychiatric records from the 19th century, though often interpreted as forms of madness or extreme impulse, rather than a specific disorder. Modern psychiatry treats autophagia as part of a spectrum of body-focused repetitive behaviors, alongside conditions such as trichotillomania, hair pulling, or excoriation disorder, skin picking. The rarity of autophagia makes it difficult to study systematically, but its dramatic presentation highlights the extremes of compulsion and self-directed aggression. It illustrates how powerful inner drives can override instinctive self-preservation, turning the body itself into the focus of destructive and repetitive behavior. Redfield syndrome. Redfield syndrome is a little-known and rarely documented condition that appears in psychiatric and psychological writings as a form of delusional misidentification. Sources describe it as involving the belief that familiar people have been replaced by imposters, or that identities around the patient are shifting in ways that cannot be logically explained. Because of the obscurity of the term, it is sometimes mentioned alongside better-known syndromes such as Capgras, Fragoli, or intermetamorphosis. The defining feature is instability of recognition. Individuals insist that people close to them, family members, neighbors, colleagues, are not who they appear to be, even though their appearance remains unchanged. Unlike Capgras delusion, where a loved one is believed to have been replaced by an identical imposter, Redfield syndrome is described as involving a more fluid sense of identity, with figures thought to alternate between real and false versions of themselves. Clinical reports suggest overlap with schizophrenia, schizoaffective disorder, and dementia, where delusions of identity are more likely to occur. Some cases link it to lesions or dysfunction in brain areas that integrate facial recognition with emotional memory, particularly in the temporal and frontal lobes. This disruption produces a mismatch between perception and familiarity, creating the impression of imposture or transformation. Unusual case notes mention patients who recognized a relative one day, but accused the same person of being a false double the next. Others describe cycles of shifting identity, where people were believed to rotate between different roles, sometimes allied, sometimes threatening. These narratives often expand into paranoid systems, where large groups are thought to be part of the deception. Because Redfield syndrome is so rarely discussed, its boundaries remain uncertain. Some researchers argue that it is not a separate disorder at all, but rather a variant of misidentification delusions already classified in psychiatry. Others treat it as a descriptive label for specific patterns that do not fit neatly into established categories. Historically, scattered mentions appear in mid-20th century European psychiatry, though without systematic study. Its obscurity today suggests that the term may survive more in cultural or anecdotal use than in mainstream clinical practice. Redfield syndrome illustrates how fragile the sense of identity recognition can be. Even slight disruptions in the brain's ability to link face, memory, and emotion may give rise to beliefs where familiar people transform into strangers, creating a world of unstable and shifting identities. Kluver-Bucy syndrome. Kluver-Bucy syndrome is a rare neurological condition caused by damage to the temporal lobes of the brain, especially the amygdala. It was first described in the 1930s by Heinrich Kluver and Paul Bucy, who observed dramatic behavioral changes in monkeys after surgical removal of these brain regions. Later, similar symptoms were documented in humans following brain injury, infections, or degenerative diseases. The syndrome presents with a striking cluster of features. Visual recognition is impaired, a condition called visual agnosia, leaving individuals able to see objects but unable to identify them. Oral tendencies are common. Patients may compulsively put non-food objects into their mouths. Hyperorality combines with changes in diet, including attempts to eat unusual or inappropriate substances. Another core feature is altered emotional response. Damage to the amygdala reduces fear and aggression, leading to unusual calmness in threatening situations or inappropriate reactions to danger. Hypersexuality is frequently described, with individuals showing heightened or indiscriminate interest in sexual activity, sometimes directed at unusual targets. Emotional flattening, lack of inhibition, and apathy often accompany these behaviors. Additional symptoms include hypermetamorphosis, a compulsion to explore and touch objects in the environment, and memory disturbances when the hippocampus is also involved. Together, these features create a behavioral picture very different from ordinary personality, profoundly altering daily life. Unusual cases have been reported. Some patients compulsively handled sharp or dangerous objects without fear, while others attempted to eat inedible materials like paper, dirt, or metal. A few showed simultaneous visual agnosia and compulsive touching, repeatedly examining objects they could not recognize. In several cases, symptoms appeared after herpes simplex encephalitis, which severely damages the temporal lobes. In humans, Kluver-Bucy syndrome rarely appears in its full form. Partial versions are more common. Children with temporal lobe epilepsy or adults with dementia sometimes display fragments of the syndrome, such as oral exploration or emotional blunting, without the complete set of symptoms. Historically, the syndrome demonstrated the role of the temporal lobes in emotion and behavior, highlighting how specific brain structures shape complex human responses. Though rare, Kluver-Bucy syndrome remains one of the most vivid examples of how neurological damage can dismantle the ordinary balance of recognition, inhibition, and emotion. Martyr complex. Martyr complex is a psychological pattern in which individuals consistently seek suffering, sacrifice, or self-denial, often to gain recognition, moral superiority, or validation from others. It is not a formal psychiatric diagnosis, but a descriptive term that appears in psychology, religious studies, and cultural analysis. The name comes from the image of a martyr who endures pain or hardship for a cause, but in this context, it refers to everyday interpersonal behavior. The defining feature is the belief that enduring hardship proves virtue or worth. People with a martyr complex may take on excessive responsibilities, refuse help, or exaggerate their struggles to highlight selflessness. Complaints about being unappreciated are common, yet offers of assistance are often rejected, as the suffering itself is central to their identity. The complex often develops in relationships. One partner may continually sacrifice their needs while blaming others for ingratitude, creating cycles of resentment. In families, a parent may insist on endless devotion to children or spouse, emphasizing exhaustion while portraying themselves as the only one who truly cares. In workplaces, individuals may take on disproportionate burdens, then describe themselves as exploited victims. Psychological explanations link the martyr complex to low self-esteem, need for control, or learned patterns from childhood environments where sacrifice was rewarded. Religious or cultural ideals that glorify suffering can reinforce the behavior, giving it symbolic meaning beyond ordinary personal relationships. Unusual cases appear in clinical and cultural reports. Some individuals go so far as to sabotage their own comfort or success to maintain the role of the long-suffering figure. Others seek out relationships in which they are consistently mistreated, framing the endurance of mistreatment as proof of moral strength. A few interpret minor inconveniences as grand sacrifices, dramatizing everyday life as a form of trial. Historically, the imagery of martyrdom has been powerful across religions and cultures, celebrating those who suffer for faith or ideals. The psychological concept of the martyr complex borrows this symbolism to describe individuals who adopt suffering as a personal identity in ordinary contexts. Though not an official diagnosis, the martyr complex highlights how self-sacrifice can shift from altruism to compulsion, transforming genuine care into a cycle of suffering, resentment, and the pursuit of validation through pain. Body integrity dysmorphia. Body integrity dysmorphia, more often called body integrity identity disorder, BIID, is a rare condition in which a person feels that a healthy part of their body does not belong to them. The most common form involves the persistent desire for amputation of a limb, usually a leg, although variations include paralysis or removal of other body parts. The individual experiences a deep conflict between their physical body and their internal sense of how it should be. The defining feature is mismatch. A person may insist that life will only feel complete if a specific limb is removed or disabled. This is not a passing thought, but a conviction that can last for decades. Some describe a sense of alienation, saying the limb feels extra or not truly part of the self. Others mark a line on their leg, knowing exactly where they want the amputation to occur. Research suggests neurological involvement. Brain imaging has found differences in the right parietal lobe, a region that integrates body representation. This area helps create the sense of ownership over body parts. When disrupted, the brain may fail to map a limb as truly belonging. Similar mechanisms are seen in neurological syndromes where patients deny ownership of a paralyzed limb, known as somatoparaphrenia. The condition is not driven by vanity or psychosis. Unlike body dysmorphic disorder, where imagined defects are the focus, body integrity dysmorphia involves otherwise normal limbs. Unlike schizophrenia, it does not include hallucinations or delusions. Instead, it is a stable identity disturbance, more comparable to gender dysphoria, where the inner sense of self conflicts with the body. Unusual cases appear in medical literature. Some individuals attempt self-amputation when medical help is denied, leading to dangerous injuries. Others simulate disability for years, using wheelchairs or crutches to live in alignment with their internal image. In rare cases, people report satisfaction and relief after elective amputation, describing a sense of wholeness that they never felt before. The condition remains controversial. Few doctors are willing to perform surgery on healthy limbs, raising ethical debates about autonomy versus medical responsibility. Critics argue that amputation in such cases is harm, while supporters compare it to surgeries performed for gender affirmation, where physical change resolves deep psychological distress. Body integrity dysmorphia illustrates how fragile and complex the sense of bodily ownership is. It shows that identity is not only about memory and personality, but also about how the brain constructs the physical self, and how, when that mapping falters, the most familiar parts of the body can feel foreign. Anthropophobia. Anthropophobia is an intense fear or avoidance of people. The term comes from the Greek anthropos, human, and phobos, fear. Unlike ordinary shyness, anthropophobia involves overwhelming anxiety in the presence of others, sometimes extending even to brief encounters or casual observation. It is sometimes considered a severe form of social phobia, though in certain cultural contexts it has distinct features. The core experience is dread of human contact. Individuals with anthropophobia may avoid crowded places, refuse to meet strangers, or retreat from all social interaction. Some feel panic simply when seen by others, interpreting neutral looks as threatening or humiliating. Daily life becomes restricted. Shopping, working, or even leaving the house may trigger distress. In Japan, a related concept, known as taijin kyofusho, describes fear of offending or displeasing others through one's presence, body odor, or gaze. This variation highlights how anthropophobia can take different forms depending on cultural expectations. In both cases, the underlying pattern is extreme sensitivity to social exposure and perceived judgment. Symptoms include rapid heartbeat, sweating, trembling, and avoidance behaviors. Many report obsessive self-monitoring, worrying about how they move, speak, or appear. Some describe the sensation that others are constantly watching them, even in ordinary environments. This overlap with paranoia can blur the line between social anxiety and psychotic conditions in more severe cases. Unusual cases appear in psychiatric reports. Some individuals refuse all direct communication, interacting only through notes, online messages, or gestures. Others wear disguises or use specific routes to avoid being recognized. In rare examples, the fear generalizes so completely that even seeing images of people on television or in photographs provokes panic. The causes of anthropophobia are varied. Traumatic social experiences, bullying, or humiliation may trigger its onset. Genetic predisposition to anxiety and heightened activity in brain circuits governing fear and threat perception also play roles. Cultural and familial expectations often reinforce the avoidance. Historically, anthropophobia has been described under different names in medical and cultural texts, sometimes interpreted as misanthropy or religious withdrawal. Modern psychiatry recognizes it as a distinct anxiety condition, though its boundaries overlap with broader social anxiety disorder. Anthropophobia demonstrates how fear of human contact, one of the most fundamental aspects of social existence, can grow so intense that isolation becomes the only perceived refuge. It shows how the human mind, when caught between the need for connection and the fear of exposure, can retreat entirely from the presence of others. Folie en famille. Folie en famille, also known as madness shared by a family, is a rare psychiatric condition in which delusional beliefs spread among members of the same household. It is part of a broader group of shared psychotic disorders, the most famous being folie à deux, madness of two. In the family form, the delusion involves multiple relatives, sometimes extending across generations. The core pattern is transmission of belief. One person, often called the primary, develops a fixed delusion, for example, persecution by neighbors, possession by spirits, or secret surveillance. Over time, close relatives adopt the same conviction, even if they previously showed no signs of psychosis. Isolation, emotional dependence, and strong family bonds make the spread possible. Medical literature describes different structures of shared psychosis. Folie imposée occurs when the dominant individual imposes their delusion on others. Folie simultanée involves two or more people developing the same delusion at the same time, usually under stress. In folie communiquée, relatives gradually absorb and maintain the belief after long exposure. In family cases, the delusion often survives even if one member recovers, showing how strongly it can become embedded. Symptoms depend on the content of the delusion, but usually involve paranoia and suspicion. Families may withdraw from neighbors, barricade their homes, or keep extensive notes and evidence. Some interpret television, newspapers, or small coincidences as confirmation. The beliefs are held with equal intensity by all involved, creating a closed system resistant to outside correction. Unusual cases highlight the reach of the phenomenon. Reports exist of entire households convinced they were targeted by conspiracies, refusing contact with the outside world. In one case, several siblings were discovered living in isolation, united by the conviction that strangers were plotting against them. Another involved a married couple and their children, all certain that they were under constant surveillance. Folie en famille is rare, but has been documented worldwide. It most often appears in households with social isolation, close emotional ties, and a dominant personality whose influence is unquestioned. Removing individuals from the shared environment often breaks the delusion, though some continue to believe even when separated. Historically, the concept of shared madness has fascinated psychiatrists since the 19th century, when French physicians first described it. The family variant illustrates how belief is not only an individual phenomenon but can also function as a collective experience shaped by bonds of loyalty, fear, and dependence. Folie en famille demonstrates how reality itself can be reshaped within a family unit, where delusion becomes the common language and shared truth of daily life. Munchausen syndrome by proxy. Munchausen syndrome by proxy, now more commonly termed factitious disorder imposed on another, is a psychiatric condition in which a caregiver deliberately fabricates, exaggerates, or induces illness in someone under their care, most often a child. Unlike malingering, the motivation is not financial or practical gain, but the psychological need to occupy the role of attentive and self-sacrificing caregiver. The core behavior involves seeking repeated medical attention for the dependent. Caregivers may describe symptoms that do not exist, tamper with test results, or even cause injury or illness. The dependent, usually a child, becomes the subject of frequent examinations, hospitalizations, and procedures. Because the caregiver often appears concerned and devoted, suspicion may not arise for long periods. Psychological theories suggest that the caregiver's identity is tied to being perceived as essential and heroic. Attention from doctors, sympathy from others, and the drama of medical crises reinforce the cycle. Histories of trauma, personality disorders, or unmet emotional needs are frequently reported among perpetrators. Unusual cases in medical literature describe striking extremes. Some caregivers moved their children from hospital to hospital across different regions, accumulating dozens of admissions. Others secretly administered medications to provoke seizures or infections. In rare cases, the disorder has been reported in caregivers of elderly parents or disabled adults rather than children. Diagnosis is difficult because the caregiver often appears cooperative and loving. Patterns that raise suspicion include inconsistent medical histories, unexplained symptoms that vanish in the caregiver's absence, and multiple unsuccessful treatments. Confirmation usually requires careful observation, collaboration across medical teams, and sometimes covert monitoring. The condition was first described in the late 20th century, expanding on the earlier concept of Munchausen syndrome, where individuals feign illness in themselves. Its recognition marked a shift toward understanding how the caregiver role itself can become the focus of pathological behavior. Although rare, Munchausen syndrome by proxy remains one of the most unsettling factitious disorders. It illustrates how the human need for attention and validation can distort caregiving into a destructive cycle, where the pursuit of sympathy and admiration is achieved through the suffering of another.